invasive techniques, and there's always going to be a role for the neurosurgeon in making the tissue diagnosis. But I think the improvement in outcome is really going to come from the molecular biologists. And what I was trying to show is the paradox here, that both the molecular biologists and the clinicians are rowing in the same direction, but not necessarily talking to one another. This new scheme, I think, is going to be helpful. It's probably going to change within a couple of years again. But we need to be able to be aware of what is being done in the laboratory to be able to translate it to the clinic. And it's being done, but I think there's still a lot more work to be done. But I think the future is going to be in molecular biology.
Thank you. Thank you, Dr. Cohen. If Dr. Eric Buffet and Dr. Steve Lowe is there, Dr. Buffet, do you have any thoughts on how we are going to progress in the next 5-10 years from what you have seen, the way the travel has been? So what's your thoughts in what's the future going to hold?
So I think neuro-oncology has been very interesting in this aspect because particularly in the glioma group, you can see that we have observed an introduction of a number of targeted treatments such as MEK inhibitor, BRAF inhibitor, NTRK inhibitor, now FGFR inhibitor. So all this comes from a better knowledge of the identity card of these tumors. And hopefully, so we have seen the issue of the diffuse midline glioma and their signature with the HK27M mutation. The dream is that we find a drug that targets this type of alteration, and we can eventually treat successfully, finally, this terrible disease. It's not yet clear whether we will see the same evolution in embryonal tumors such as medulloblastoma. We have seen 10 years ago the introduction of sonic hedgehog inhibitor with very little success and concern about the toxicity. But it's clear that there is a trend now toward a sort of progressive change from chemotherapy and radiation-only approach to a more targeted treatment. And of course, the issue is, will this be a privilege of high-income country, or when is this going to come into the practice in all countries around the world, because there is a cost associated with this. So I'm sure that Daniel and Ibrahim can comment as well on this.
Thanks. Dr. Qaddoumi, do you want to comment, please? Thanks. You have to
unmute Ibrahim.
Okay.
Thanks.
Okay. So I have unique perspective because I worked in a developing country as a neuro-oncologist, and I worked in one of the most advanced places in the world. We have no problem getting any targeted therapy. Part of my problem with this, and keep talking about targeted therapy, it really make us deviate about the most important therapy to cure low-grade glioma, and that's in neurosurgery. Our neurosurgeon, Rick, always recite that paper, I forgot the main author, where you can cure more than 70% of low-grade glioma by neurosurgery. And I always tell my colleagues in developing countries, if you really have $120,000 to spend on 1 year of selumetinib, please spend it on sending a neurosurgeon to one of the advanced countries or centers to, thank you, Daniel Wissoff, thank you, to train and come back and be a good neurosurgeon. And that neurosurgeon will not only cure low-grade glioma, because I assume if you're good in curing low-grade glioma, you will be good as a neurosurgeon and other things. That's my main problem with talking too much about targeted therapy. I use it. I'm making a career of targeted therapy. I'm not against it. I really think we always have to emphasize in neurosurgery first.
Thank you, Dr. Qaddoumi. And Dr. Stephen Lois is once again very pro neurosurgery oncologist. I always consider him in my own mind as a neurosurgeon who is a neuro-oncologist. And Dr. Lois, where do you see the future, and where do you see the importance of surgery and these targeted therapies and chemotherapies, and in terms of money as well, resources as well?
I think the comments have been entirely accurate. You can manage most of these patients with surgery, and if you are trying to use your money most efficiently, then training people appropriately is going to be more effective. But pharmaceutical companies charge what they can and will. Over time, you hope that those costs will come down and they'll be more accessible. I guess in a country where resources are very limited, the complications of therapy with chemotherapy are not supportable either, and therefore any therapy which could be given which reduces those complications is likely to be useful. I did a little work in Uganda, and it wasn't even possible to do a full blood count for some patients. So in those situations, then you have to think, how on earth can you manage a tumor unless it has very little toxicity?
Thanks, thank you. We have got Professor Groton-Hughes here as well, and I had a chat with Professor Groton-Hughes going back 5 years ago. I know Professor Groton-Hughes and Dr. Cohen go way back than that. In terms of the neurosurgical training, do you think that the neurosurgical trainees should spend time in molecular biology or do a PhD in molecular biology, those with those interest in tumors, to make sure that we are not out of this ship? Professor Groton-Hughes and Dr. Cohen, thanks.
Well, Naren, I think that at least they need to have the understanding of what they are talking about and what they are reading in a histology report. I don't know if it is necessary to really spend time in it. As it is mentioned, it is better to spend the time in being well trained in performing the surgeries. But of course, you should. The same is the question, do you have to spend a year in radiology to really understand MRI scan or CT scan? I think anything that involves that part of neurosurgery so that you can talk to your pathologist, I think that's necessary. But I don't think they really have to spend time in it. They have to spend some time at home studying this.
Thanks, thank you. Dr. Cohen, your last words from you, Dr. Cohen, your thoughts on all the comments mentioned and neurosurgical training in future. Thanks.
Yeah, I appreciate all the comments, and I would like to say that Dr. Groton-Hughes is way too modest to be a neurosurgeon. He is one of the leaders in the field, and I take everything that he says seriously, but his humility is something that's unusual for a neurosurgeon. But I agree with him completely that I think we need to have some kind of knowledge about what's going on in the laboratory to be able to communicate and to be able to translate this more effectively for our patients. But I think the other thing, which we didn't spend a lot of time talking about because this field is so rapidly moving in the molecular world, is surgical judgment. And that's one of the things that, a patient where a radical or gross total resection will be the optimal therapy that comes at a cost. One has to balance that. And there are a lot of issues in surgical judgment that we haven't talked about. And I think that's probably the most important thing for a surgeon, which happens outside the OR.
Thanks. Thank you very much, Dr. Cohen, for that excellent lecture. Dr. Cohen is going to be publishing on this area, and once he has published it, he would kindly give us permission to put that lecture for everyone to see on our YouTube channel. Thank you very much again, Professor Cohen. So now I'm going to pass the baton to Dr. Lois, Stephen Lois, to introduce our next two speakers. Thank you, Dr. Lois. Thank you.
Thank you very much, Naren. So I'd like to introduce the first of two talks, one by Dr. Daniel Moreira, one by Dr. Ibrahim Qaddoumi, both of whom have participated already today, and both of whom have worked with Eric Buffet, and so I would be interested to hear their perspective on the theme of this afternoon. My understanding is that I don't know Dr. Moreira, but you are a neuro-oncologist in St. Jude's, and you have an extensive interest in medical education and in neuro-oncology generally. And your talk is going to be on early diagnosis, so I look forward to hearing from you.
Thank you. We have just lost Dr. Qaddoumi. I think he's probably going to reconnect. So while Dr. Qaddoumi is connecting, Dr. Moreira, do you want to start your talk, if that's okay with you? Let me, I think Dr. Qaddoumi is here. So we will go to Dr. Qaddoumi. Let's see, he's going as group 1. Let's see. That's why I can get it.
Okay, with Dr. Qaddoumi talking,
yeah, thank you. So we'll go with Dr. Qaddoumi. Thank you, Dr. Qaddoumi. You should be able to share your presentation. I have to say, I spent a month with in St. Jude because St. Jude has this scholarship to come to their department, and I really spent a fantastic time there with Dr. Qaddoumi and colleagues, and with Dr. Rick Boop. And it really was, you know, if you guys are interested in neuro-oncology, certainly it's a mecca to go to, and they do look after you. And I hope Dr. Qaddoumi will touch on the systems that they have, or Dr. Moreira. Thank you.
Okay. Can you hear me?
Yes.
So just to correct the introduction a little, thank you very much for having us. For us to be part of this course that hosts what I call titans of neuro-oncology or childhood brain tumor, we're very honored. I'm the one who's interested in early diagnosis. Dr. Moreira is a neuro-oncologist, but he's really also interested in education, and he's really modest about it. So I'm going to say a little word about this. He's really revising the way we do education in oncology, and especially in neuro-oncology. Some of you may have seen his paper in Cancer about the Neuro-Oncology Academy, and we are hosting, or he is hosting, the second Neuro-Oncology Academy, with it tripled the size. One of the main successes is how many neurosurgeons are participating, and you're going to hear about this academy more and more in the next 10 years as we expand it. So keep an eye for that. I just wanted to correct this because I'm not the one who's interested in education. I'm interested of it, but not my focus. I'm interested in early diagnosis mainly and low-grade glioma. So thank you for allowing me to talk, and I hope I will stay within time. So these are my conflict of interest. To let you know about it. So whenever I discuss any targeted therapy, keep that in mind, but I will not discuss that in this talk. This is the outline of my talk. And I learned some of these outlines from presenting to medical students. Medical students are one of the most amazing group. Their thirst of knowledge and their curiosity really makes you change the way you think. So I like to present to medical students whenever I get a chance. I've been working on low-grade gliomas for 20 years, since Eric Buffet started mentoring me in Jordan 20 years ago. And I became more and more interested in it. I think part of the problem for low-grade gliomas and delayed diagnosis in general in children is the way we teach medical education. That's how I came to see it. We still emphasize the triad of headache and vomiting and papilledema. Delayed diagnosis in brain tumor is a unique problem. Like, there are at least 4 studies I'm aware of where, and I recently reviewed a paper from Sweden. It showed the same thing, and hopefully it will be published soon. Parents do better than physicians. Imagine if one paper comes and say that in the ER, the patients diagnose their heart attack better than the ER physician. It will make news on CNN and BBC and all over the world, and something will be done about it. But children don't advocate for themselves, so we can't ignore them. Delayed diagnosis, in fact, was found by many papers, and that's American literature, because we always worry about getting sued. That delayed diagnosis is good prognostic indicator. So if you do a bad job and you are delaying diagnosis a child or a young adult with brain tumor, it's not bad because it's better prognosis. And that's nonsense, because these studies mixed high-grade glioma and low-grade glioma and craniopharyngioma. And of course, if you diagnose a glioblastoma in 1 week, the patient will still die. But if you diagnose a low-grade glioma in 2 years, the patient will still live. And that's part of the problem also. Patients don't die in low-grade tumors. I'm emphasizing low-grade tumors a lot. You will see why. Because they really have good prognosis. And emphasis should be not on survival. It should be more on functionality and outcome, as we see. Just to show you an example why I think it's education. Wilms tumor, it takes 2 weeks to be diagnosed. Leukemia, it takes 1 week. Brain tumors, 14 to 16 weeks. I just want to remind you, these are Western studies. And we can make excuses. It's easy to diagnose leukemia. It's easy to diagnose the tumor. It really, in my opinion, it goes about education. It was ingrained in me that if you have fever of unknown origin, think leukemia. If you have a bleeding of unknown origin, think leukemia. It was ingrained of me that any patient with hypertension or raccoon eye or abdominal discomfort to do a good abdominal exam. In my medical school, you fail if you don't do a good abdominal exam in the practical part of the test. So over the last 20 years, my bias became towards education. That's why I like what Daniel is doing. Just to emphasize the point I made. This is a slide I start with medical student, and I'm sorry, the group here is really does not need basics, but I hope also to change your the way you think about education, and you start looking at teaching brain tumors different in your institution. So pardon me for if I'm a little basic here. I put this slide and I ask the students or residents, what's the first thing that comes to your mind when you hear a brain tumor, and ask them to raise their hand. And a lot will think glioblastoma, medulloblastoma. Recently, it's starting to become more and more low-grade glioma or pilocytic astrocytoma. Pilocytic astrocytoma alone is more than medulloblastoma. But we talk about medulloblastoma much more than pilocytic. If you add low-grade gliomas, you're really talking about 50%, in my opinion, of childhood brain tumors to be in the low-grade glioma group. And we showed that in a series study, although others did not show that. But most of the studies will talk about 30 to 40% of childhood brain tumors, low-grade tumors. If you add low-grade glioma, if you add craniopharyngioma, other low-grade tumors, I really think we can say with comfort that 50% of childhood brain tumors are low-grade tumor, if not more. I really think emphasizing this will cause us a paradigm shift in the way we look at the brain tumor. I use this slide and I call it the senator syndrome, glioblastoma as the poster child. Even in the media, when you think of a brain tumor, you think of celebrities, and the way they presented is acute diagnosis. Both senators, I think, were diagnosed within a week of their symptoms, and both died within 13 to 14 months of diagnosis. The time here is time to diagnose and time to death, not time of birth to time. I'm sorry, I should have, but you can see that Senator McCain, 13 months died. Senator Kennedy, 14 months died. And that's what ingrained in us, in education and in the media. The brain tumors, acute presentation, and then subacute death over 1 to 2 years. Even with the best treatments, they both got the best treatment for an adult brain tumor. I'm one of the people, I'm internist also by training and pediatrician. I did med-ped combined residency. And I used to tell some of the mothers or the young patients when they ask me, I have these symptoms for 3 or 4 years. Could it be a brain tumor? And honestly, my answer was, if you have a brain tumor for years, you should be dead by now. Sorry, it should be by now, not by now. And I said that multiple times to patients. I used to feel guilty when I started becoming a neuro-oncologist, how many patients I missed. And I hear the same story of my patients. In fact, the head of the International Brain Tumor Association, she shared with me the story of her son, who was a rugby player having refractory headaches for 3 to 4 years. And she said at one point, the doctor told him, suck it up. It's not like you have a brain tumor. And then he was diagnosed with a low-grade tumor and died from it. It's not the doctor's fault. It's the education system fault, because this doctor was taught to think you cannot have a brain tumor for that long and not die or have a neurological symptom. He could not comprehend how a rugby player who can have a good game could have a brain tumor. That's how we teach medicine. This is the paper I referred to, and I'm going to be fast about it because I already mentioned it, but we found in the SEER data, and for people who are not American, the SEER data is represent 19 states in the United States who deposit their cancer patients. So, most of the tumors were high-grade, were glioma, and almost 80% were low-grade glioma. So it was about 50% of these patients up to 21-year-old to have low-grade glioma as the main tumor. Even in adults, I mean, this is from the CB Trust data. Even in adults, it's even more. In adults, most of the tumors are low-grade tumors, meningioma, pituitary adenoma. Recently, I published a paper about psychiatric presentation in low-grade tumor, which is low-grade glioma and craniopharyngioma. And when I was reviewing the literature 78 years ago when CT scan presented, it was amazing how many papers were published on patients being diagnosed with a huge tumor after dying in a mental institution or when they were started screening them with the new technology of CT scan. So again, I know I'm repeating myself, but I cannot emphasize it in my mind enough. It's about education. I really think if we start telling students and residents and nurses that low-grade tumors are the most common tumors, it will cause a paradigm shift in the way we think. In the literature of children, the triad of headache, nausea, vomiting, and also it says morning and papilledema happens in less than a third of the patients. So most of these patients don't present the way we teach it. And that causes confusion to medical students. This is a paper we wanted to look after. I saw the literature about how delayed diagnosis is good prognostic presentation. We wanted to take it at St. Jude a further step, and we looked at grade 1 versus grade 2 even. And there was difference. I want to show you the good survival. 88%, 11 years follow-up. And I think that's most of the studies. So patients with low-grade tumors, if you delay diagnosis, they do not die. So that's why we should stop looking at overall survival as an outcome. We should look at what I mean it should not be our guiding. And we found interesting data, some of it similar to others, some of it were not. But even between grade 1 and grade 2, there is a difference. The older children take longer, and that makes sense. Adolescents are always the worst in any healthcare system because it's not only their fault, it's our fault also. If adolescents don't talk to us, we're happy and we leave them alone. One of the interesting things for me, at least, and that emphasizing neurosurgery, is when we talk about that delayed diagnosis is associated with a progressive disease. And if you take care of a low-grade tumor that missed the opportunity to be resected, then you know this is a chronic for life problem. At St. Jude, we're lucky. We treat patients even after they're 18. I have patients who are 30-year-old who are still dealing with relapses of low-grade tumors and its complications. And I cannot emphasize this enough. And that's why I think education also will help our neurosurgeon. I'm not a neurosurgeon, but I really doubt any neurosurgeon will argue that 1 centimeter tumor is less easier to resect than 5 centimeter. Also, one of the terms I was taught when I was a medical student, I like it, is the Goldie rule, which it says that resistance of chemotherapy or treatment is associated with the size or the number of cells. So the more tumor you have, the more resistance to treatment. And this, for me, I use it to justify my pushing for early diagnosis and early resection. Spinal tumors are the worst of the worst. There are multiple studies. I'm aware of one from Israel. Shlomi does a lot of work on delayed diagnosis, and one from UK. And we showed the same. Spinal tumors are the worst of the worst. And in my opinion, it goes back to education. We really get taught that chronic back pain is acceptable. Keep in mind, 90% of education to medical students is adult education, not children. So we are taught it's acceptable to have a chronic back pain. 33% of the population have a chronic back pain. But in my opinion, in a child, it's not acceptable. And I'm not saying every child with a back pain should get MRI. All what I'm saying, good history, good physical, and good follow-up. I'm going to emphasize, these are the objectives of my talk, but really the main objective is, again, and sorry for keep repeating myself, is we have to cause a paradigm shift, and we need to emphasize that most brain tumors in children and adults are low-grade tumors. And I use this phrase, the eye does not see what the mind does not seek, and this was when I visited Egypt after the turmoil, and they said it to me in the political context, where half of the country doesn't see what the other half country think about politics, and we have the same problem in the United States, but I use it in medicine. If you don't think of something, you will not find it, even if it hits you in the face. And I hope we stop this thinking, if you have a brain tumor, you cannot be alive for many years. You could be. And again, I'm not advocating more imaging, because that can be very dangerous, especially in developing countries where people pay cash. And if you ask a parent to pay 1 month's salary to do an MRI, and that MRI is negative, that can have major complication on their family well-being. All what I'm advocating, change the education, do good history and physical, and follow up. There is no rush, since most of these are low-grade tumors, unless there is increased intracranial pressure or seizure or major neurologic deficit. There is no rush in doing MRI, but there is continuous follow-up. You have to educate your patient to come back to you if they don't, if the diagnosis you gave them is not improved by the treatment. If you tell your patient you have sinusitis and you give them antibiotics for 2 weeks, make sure you tell them, if the headache does not improve, come back. If you give a migraine diagnosis and they don't improve, make sure you tell them to come back. So good history, good physical, and follow up by educating patients. Again, always my concern when I do this advocacy, I'm always worried that I will cause more damage than benefit by making people do 100 MRI to get one diagnosis of a low-grade tumor. These are the risks of imaging, and I teach it to medical students and residents, so I will pass this one. But it's very important to educate people about risks of imaging so they don't overdo it. I want to summarize the literature that I came across over the last 20 years, and we published that in our paper, but these are the main causes, in my opinion, for delayed diagnosis, but really it comes down to brain tumor education, and emphasis on low-grade tumors. As I will show you in the next part of my talk, where I present real cases, which I'm sure you all have similar cases. Even in the WHO book, and I try to change this, they still advocate the triad as the way brain tumor present. And that WHO book for early diagnosis of cancers is distributed around the world. I don't know if they changed it after my letters to them, but the last I checked, it was still there. And keep in mind, it really comes down to time constraints. And think of the time constraints we have, multiply it by 10 times in developing countries. That's why I think we have to come up with better strategies for our colleagues in low and middle income countries on how to help them diagnose these tumors. And that will help their neurosurgeons, who are very busy, to have better surgeries and less time operating. I came up with this talk, with this part of the talk 7 years ago. Some of the students and residents told me, we don't want only just theory and papers, we want real cases. So I started sharing these cases I have faced over the last 20 years. And sometimes I will ask them, where do you think this case in Jordan or in United States? And they get surprised how we are not much different than developing countries in diagnosing brain tumor. This is a real case I have. The child was starting to have headache at age of 5. It woke her up at night, sometimes at school. It lasted 2 years, the same. So far, nobody thought of a brain tumor. At age of 7, she started having a stiff neck. And she went to the ER and X-ray of the neck and sinus, and that's something they love in ERs, sinusitis or neck pain, and both were normal. So the family was assured and were told to take Tylenol and use airplane pillow, which of course helped her. So mom said the symptoms wax and wane, but she still have some good days and some bad days. She went on a trip and forgot the airplane pillow. So the symptoms, of course, intensified. And that's one of the things it's hard for us to think if you have a brain tumor, you should continue to get worse, because the brain plasticity is a new thing for us and we don't emphasize it. We forget that the brain can adapt and the symptoms can improve even if you have a slowly growing brain tumor. The headaches started getting worse at school, and the school will call the parents. Neck pain. She became tired and sleepy. I want you to think how many red flags she had so far. Nausea and vomiting, and not feeling tired, and feeling tired all the time. She was seen by an ophthalmologist who gave her glasses and no explanation for the headache. She was seen by a neurologist who diagnosed her by migraine, and no treatment was given. So 3 weeks before diagnosis, she had 3 ER visits, and twice she was told stomach virus. The third time, the mom was determined, and she said there was a history of kick to the head. I never asked the mom, and I don't have this patient anymore, if she lied or this was a real thing that happened, because sometimes patients may lie to get what they want if they think it's needed. And finally, a CT scan was done after 3 years of suffering. So when I present this case, before I show you the MRI or the CT scan, I tell the students, I want you to think, if these symptoms in this child that happened over 2 to 3 years happened over 2 weeks, where nausea, headache, vomiting, blurred tiredness, sleepiness, waking her up at night, if these symptoms happened within 2 weeks, how many physicians do you think will miss this child? And they all said this child would have had an imaging. And I think it's the same, the problem for this child, that the symptoms were slow and gradual, and that's what misled everybody. And the diagnosis was a low-grade tumor, and the child is alive, but I think, if I recall correctly, significant deficits. This is an interesting case I had. The patient had 4 strabismus surgery before the ophthalmologist finally decided to think maybe there is something wrong, because the strabismus surgery kept failing. And the child finally had an imaging that showed a tumor, a huge tumor. This case is from Jordan. The other case was from United States. I'm not sure if I said that. This is another case where parents do better than physicians. This father was a blue collar from Jordan who make less than $300, and he was obsessed with his first daughter, firstborn, it was a girl, and he did not understand why his daughter will have a unilateral nystagmus. And many physicians told him children with in the first year have misaligned eyes. I was taught that, frankly. That it takes time to adjust, and he did not accept no for an answer and insisted on imaging. And look how small the tumor compared to the physician diagnosis. I don't think we can argue that he did better than many of these physicians. This is a very interesting case. The child was at the age of 12. She started having symptoms. With right pinky started curving, then more and more fingers started curving, then the hand, then the shoulder, then the right side of the arm, the right side of the body. She was shuffling her feet like an elderly with a stroke. The first diagnosis she was given by the teacher, the way you hold the pencil, and everybody latched onto this one. One of the interesting studies from Israel, Shlomi again, he talks about that if the first opportunity of that's the way I understood the study. Maybe that's not what he meant. If the first diagnosis or first visit is not the diagnostic visit, most of people will tend to follow the first diagnosis and miss the opportunity of diagnosis. And in his study, he mentioned that especially if the first visit was done by a specialist, like a neurosurgeon, neurologist, or ophthalmologist, then the child is doomed to be delayed diagnosis. And I will show you a case from Jordan. And in our new paper last month in psychiatric presentation or behavioral and psychiatric presentation, I call it diagnostic imprinting. We are familiar with the imprinting. So the first person who gave a diagnosis, we all follow it like the ducklings that follow their the first face they see. Diagnostic imprinting, this is something I came up with, and hopefully it will change the way we teach medicine. And she was seen by a neurologist who did EMG and a pediatrician who assured the family. The nurse practitioner, again, this is in the United States where we have nurse practitioners, did not think that someone with that much neurologic deficits should not be investigated and insisted on a brain MRI. This is not the brain MRI, this is the planning of her radiation field. And you can see the child is alive and going to live most likely, but this child will never be an independent citizen, and she will be always a burden on the society and her parents and her family. And her family and she will suffer for the rest of her life because of the delayed diagnosis. This is before I started doing the global at St. Jude, I used to think this is a problem in Jordan first, then in United States, because most of people don't have insurance. Then I came across the work in UK about Head Smart and other countries, and I realized really it's a universal problem. And in my opinion, it goes back to education. This 4-year-old was diagnosed with malnutrition at age of 8 months, vomiting post meals since age of 12 months, weight less than 10 kilogram, and genetic workup was within normal. Endocrine workup was within normal. Finally, someone thought of an MRI. If you think about it, this is what we teach students. One of the differential diagnoses of failure to thrive is a brain tumor, diencephalic syndrome, and we don't emphasize it enough. I want to take a step back to my paper about psychiatric presentation. One of the psychiatrists, I forgot where he's from, Madhusisin, really published a very nice paper 7 years ago, and I used it as an example for our paper about how, when he looked at the literature, I think half of patients with anorexia nervosa were really diagnosed with a midline tumor. And I always wonder how many of these young women we forced to have TPN or feeding a tube before we looked into a brain tumor. And I say young women because a study from UK a few years ago showed that the ones who are most discriminated against in this issue are women and poor. The poor makes sense. We're all biased against the poor, but women also it makes sense because whenever a woman have a chronic problem, we say she's crazy or it's that time of the month. The society have tendency to discriminate against women and the poor. So I always wonder, after I read Madhusisin's paper, how many, I'm sorry if I'm saying his name wrong, how many of these young women we forced to have TPN or feeding tubes were having midline tumor. This case from Chile, I was told in Chile, everyone have insurance. Even if you are an illegal immigrant, you have insurance and you have the right of healthcare system. So it's not about access. It's about education. And I think the work in UK with Head Smart showed again, it's not about access, it's about education, because in UK, everybody have insurance and everybody have access to a general care provider. This is a similar case of failure to thrive. So for the sake of time, I will be a little fast, but this patient got everything, every test you can imagine. And the family even asked for an MRI because, again, I'm not advocating we should listen to the parents in everything. The final decision should be for the father, for the physician. But I really think we have to include the parents in the discussion and take their concerns seriously. This patient had everything before MRI. And that's the tumor. This is in the United States. That's an interesting case that emphasizes the point that Shlomi made in his paper, where if a specialist misses a diagnosis, then the child is doomed. This is a real case of mine in Jordan. The child was starting to have seizure at age of 5. And Jordan is a small country, and she was seen by every neurologist almost and every neurosurgeon. The father have a big suite of EEGs, and the child was on 4 anti-seizure medications. She was 17-year-old functioning at a level of 3rd grader in her reading and writing, and we have to get a private tutoring at King Hussein Cancer Center to re-educate her, because this child was on 4 anti-seizure medications. So she missed half of days of schools, and even when she was in school, she was drugged and not able to learn anything. And I was told by the family that she had a CT scan at age of 5 that showed it was negative. And I tried my best to get this CT scan. I have a feeling there was a small ganglioglioma in the cortical area that caused her the seizure, but I couldn't get it. This CT scan I'm showing you is at age of 17, after 12 years of suffering. And gangliogliomas are notorious for having more than 1 decade of being diagnosed. There are a lot of literature on gangliogliomas specifically. They're one of the worst low-grade tumors. This is an interesting case. The parents did everything. They went to the physician when the child was walking funny, having a weird voice, and they were told that's normal. At one point, the mother was not allowed to see her parents for 5 years because the father did not like the parents. And she, at age of 7, luckily for the child, she got divorced. When she went back to her parents' house, the grandmother, I still take care of this child. The grandmother did not believe how the child was walking like a patient with a stroke, and nobody did anything about it. She took him to a pediatrician, and the pediatrician was more worried about the new hearing loss, not the 5 years of weakness and progressive weakness. So referred the child to an ENT. The ENT have good clinical sense, and he did an MRI. The ENT was more worried about the weakness than the hearing loss. And I don't show the whole thing, but most of the spine was full with a tumor. This is a case, another case about the psychiatric condition. The child was given 3 psychiatric diagnoses, in fact 4 if you add ADHD. Finally, she started having worsening headache, and an MRI was done, and it showed left cingulate gyrus tumor. And I believe her, I did not follow her because it was a surgical case and not part of St. Jude, but I was told her symptoms improved. In fact, my neurosurgeon told me one of the treatments for refractory OCD now is left cingulate gyrus resection. This is her tumor. And when I present to our psychologists and psychiatrists, they get mad at me. They say, do you know the cost of MRI if we start doubting the psychiatric conditions? My response will be, it's not more expensive than giving someone Zoloft for many years. And I have a problem in the United States, the way we practice medication control. Like I cannot give meropenem without ID control. At St. Jude, nobody can give even basic drugs like vinblastine or everolimus, which are basic chemotherapy, without being an oncologist and getting a training in. But any one of us can prescribe Zoloft without hesitation. And I always wonder if this is similar to the opioid pandemic, where pharmaceutical pushed on us to make easy access to psychiatric drugs. I'm not against psychology as a field. I hope I don't come across like that. Psychiatric conditions are a real thing, and people should have access to psychiatric treatment and psychiatric diagnosis. All what I'm saying, children are not young adults. And if a child is having severe psychological symptoms or behavior, we should first investigate the school and the house to make sure there is no abuse, nothing that causes this. And second, we should make sure there is no neurological diagnosis because of this, before we commit the child for years of Zoloft and other therapies. This is another case. I'm sorry, that this was an email consult, but the child was given the diagnosis of convergent disorder. And part of my oversensitivity maybe for this issue, because psychiatric field outside the West is really not well developed. And if we are liberal with psychiatric diagnosis in other countries where you do not have good psychologists or psychiatrists or even pediatric psychiatry or psychology, then many of these children will be given unnecessarily psychiatric or psychologic diagnosis. I'm going to just push through the presentation just for the sake of time. This is another case from the literature. This is not my case, but the child started with having torticollis, and again, many years of misdiagnosis. Finally, an imaging was done. I want to emphasize eating disorders again in our recent paper, and that's not a new finding, but we wanted to emphasize it. In low-grade gliomas is diencephalic syndromes or anorexia nervosa. In craniopharyngioma is overeating or hyperphagia. This is an interesting case going back to the spinal tumors that we talked about, that I talked about, and others showed the same issue. This child was lucky because our neurosurgeons interact with St. Jude a lot, and they wanted to investigate why a child have a a chronic back pain. The child did not have any neurologic deficit, just chronic back pain. I want to use some of the quotes from the UK studies to show you how we are biased against women and the poor. These are real quotes from real patients. And you can see how these patients were labeled as drug seeking. And again, I'm not saying that we don't discriminate against adults, but my talk is about children. And I will always want to remind people that we should practice what we say. When we say children are not young adults, we should really practice it. How many of you think a 7-year-old will be a drug seeking? There is really no incentive for a mom to come to the emergency room in the middle of the night with a crying child and leave her other children. The pediatric field is totally different than the adult field. And I'm saying this because in the United States, we have, if you work in a metropolitan ER, you really get unfortunately desensitized and start not believing your adult patients, because there is always, because of lack of insurance and social issues, patients come to be just admitted and get a warm meal because they cannot get access to, it's a messed up system. You cannot get legal access to primary care, but legally you can walk into any ER and have any complaint and we should be seen. So people use ER as primary care or a way to solve their social problems. So you become, as a physician, desensitized, unfortunately, and that's affect the way you look at your children patients. Again, these are stories from UK, and if everybody have access, imagine what's the problem in other parts of the world. I already mentioned this, so I will, again, I want to update the causes that I reviewed in the literature. I really think it's back to education. We should emphasize that the chronic pain is not, chronic back pain is not acceptable in children. Again, not immediate imaging, but at least some follow-up and investigate before clinically to decide if you have, if you need imaging. This is an acronym, and I hope to disseminate. Law or pay. You know, in United States, we always worry about being sued, so I use this to scare people. But I tell them in the talks, it's the patient will pay the price. So these are things, red flags. I always remember when I was medical student, my mentor taught me the 4 W's for fever after surgery. And I wanted to come up with something that helps students and residents or ER physicians to think of a brain tumor better. This is something from a medical student in Turkey who listened to one of my talks. She agreed for me to share her email. And she told me one of the patients, it drove 2 hours to come to the ER in the middle of the night, and they were poor. And she said that she did not want to not believe the parents, but it was very busy. And this student was even better than me. I'm trying to learn from her strategy to come up with 5 minutes exam and history, focused history, to help physicians do a better diagnosis. She really did an amazing job, and she was able to manage a case, diagnose a case with a brain tumor that nobody else diagnosed before. I use this slide to brag a little, but also to mention when we were in South Africa, my wife forced me to do this swimming with a great white shark. And I bought a camera with 27 pictures. I was so scared and cold. I did not look, I did not do anything. I just kept clicking. And only one of these pictures managed to catch the shark. And I use this because I tell students and residents, my goal of this talk is not to make them take 100 pictures to catch one. I want them to become more professional and do better job. Try to see what's going under the water, feel what's going on. Try to see some guidance before you take the picture and diagnose. Don't do like me, just click, and then waste a lot of pictures before you get one good one. Thank you, Naren, and thank you everybody for this great course and for allowing me to be part of it with such amazing people. I'm sorry if I took extra time.
Thank you very much, Dr. Qaddoumi. And may I just apologize for giving the wrong introduction to your talk at the start. Dr. Moreira is going to get 2 introductions. I share your frustration. And I can tell by the way in which you spoke to us, the emotion behind many of these cases, which are always very distressing when you have very late presentations. My question, I suppose, and maybe it's just a comment, is that when we learn pediatrics as medical students, we're often taught this is the common thing. These are the probable causes of illnesses. And the emphasis is very much on getting patients through their treatment, through diagnosis. And there's an emphasis on, for example, the benign respiratory diseases or some sort of membranous problem. Do you think it's time that we should be trying to modify pediatric training at an early stage so that people focus on the thing that's going to kill you before you make the benign diagnosis?
Okay. That's why it's a very good question and provoking one, and I appreciate it. It's just, that's why I emphasize to the students that I do not want you to miss a cause of a migraine headache or bad tooth for headache. But I always tell them, keep in mind these are low-grade tumors. Unless you have signs of increased intracranial pressure or seizure, newly diagnosed seizure, or major focal neurologic signs and symptoms, there is no rush to make the diagnosis. You can take your time and educate the patients. If this diagnosis I'm giving you, or the observation period, I cannot emphasize educating the patient. You will be surprised, even in the West, how much our patients trust us blindly. If you tell them nothing going on and you send them, they may continue to have headaches for many years and just ignore it. You have to tell them, if these symptoms come back, don't improve, come back. So I'm not saying we should ignore other causes of headache or vomiting, especially in developing countries where you have so many infections, and start thinking for the one low-grade tumor you may see in your lifetime or may not. All what I'm saying is we need to teach them that there are the good history and good physical and brain tumors. When we teach brain tumors, we should emphasize to them that most of it is low-grade tumors, and these things have a very weird and diverse presentation, and the patient can be alive for many years before they get diagnosis. I hope I answered your question and not dance around it.
Not at all. I'm really just walking alongside you, because I have a number of patients like you do who shock you with the way in which they've been neglected as they go through the system. And sadly, I think your diagnosis of imprinting is very accurate.
I would love, one of the new projects I'm thinking about with Daniel and Rick and our neuro-oncology in global, and thank you for mentioning this, and I know this will be self-serving, but please allow me this. One of the projects I'm thinking about, and I will start hopefully soon, is to collect these cases in a survey and will send emails to colleagues and ask them to share cases like this. So please keep these cases. I think the more we publish about this, the more And that's why I love the Shlomi paper, because it's amazing. If a neurologist or a neurosurgeon misses the diagnosis, the child is doomed. And it makes sense, especially in small countries like Jordan and Israel, where are 5 famous neurologists, 5 famous neurosurgeons. And if I'm a pediatrician and they will come to me and they will say, well, Constantine saw my child and he told me this headache have no brain tumor cause. What's the chances of me as a small pediatrician will challenge the diagnosis of the most famous neurosurgeon in Jordan or Israel? That's why I love that term. I know, again, I'm complimenting myself, but I call it diagnostic imprinting, because it really, that's what happens. The first diagnosis, we latched onto it and the child is doomed. And that's why I emphasize that we should not do bad imaging. One of the things I failed to mention in my talk, we should communicate with the radiologist. We're not fair to our radiologist. We send them, rule out the tumor or mass occupying lesion, and the neurologist is, the radiologist is not trained to look at midline or small cortical tumor. They're trained to look for big things. So that's why if we do bad imaging in the beginning, we doom the child also, like that case from Jordan. So another reason I don't advocate imaging a lot is because a bad image in the beginning can also doom the child. And we need to talk to the neurologist. The neurologists need to know that you're seeing a child with a precocious puberty, not headache. So they look at the midline. I have many cases, the patient had MRI at the beginning, and that's it. Nobody thought of repeating the MRI. And that's why I worry about a lot about, because sometimes, like Mark Twain says, it's not the things that you don't know that hurts you. It's the things that you think you know for sure that hurts you. And I'm always worried. I'm so passionate about this that I may cause more harm than benefit by making people pious and keep doing imaging unnecessarily. I don't want to be too passionate. I want to be passionate about it enough, but not too passionate to make people go crazy and start doing imaging. And I always worry about how I may cause more damage.
Excellent.
Steve, can I just make quick 2 comments? I think Dr. Qaddoumi mentioned, I think I had a patient while I was in Bristol, that the ophthalmologist had initially seen the patient and thought it was a drusen, and then the delay of the tumor was a year later. So sometimes, I agree with you that if the specialist has seen and said things are okay, then it really can sometimes push things very further down. The other thing is that, I don't think I will be able to do it, which I wanted to do, maybe when one day I come back to pediatric neurosurgery. But the thing is that, I wanted to have a website that was for neurosurgeons, from neurosurgeons for general practitioners. And with with Zoom, you can have, neuro-oncologists or neurosurgeons running courses for pediatricians on these matters on quite a large scale. And actually, having talked to a lot of pediatrician GPs, primary care physicians, they are keen to learn, and they usually don't have that much contact with the neurosurgeons as well. But I think technology is changing, and I think it's for the neurosurgical community, pediatric neurosurgery community, or the neuro-oncologists to try to reach out to the primary physicians. I think they will welcome it.
Thing about, sorry.
Sure.
That's why I think the new generation, like Daniel, the new breed of neuro-oncologists is really important. Having someone like Daniel with expertise in education and expertise in neuro-oncology will help our efforts a lot. Because one of the things I learned from him, he said, imagine if you are a dean of medical school and you have patients dying of COVID, and you go and tell this dean, I want you to dedicate 2 hours of curriculum for your medical students every semester to learn about low-grade tumor that they may never see in their lifetime. He will throw you out of his office because there is a pandemic. So that's why I think having Daniel and people like him is really important, because we need to find the right balance of education and not focus on, we need to be aware, like the question indicated. We do not want to go to the other extreme, teach about rare things and forget common things.
Excellent. That was a very good segue, I think, into perhaps moving on to Dr. Moreira's talk now. thank you very much for your excellent talk today, Dr. Qaddoumi. Could I now reintroduce Dr. Daniel Moreira, who is at St. Jude's. His talk will be on early diagnosis, but his particular interest, as Dr. Qaddoumi has said, is on medical education and presenting novel ways of making people aware of the issues related to brain tumors. And the improvement of outcomes of children with cancer in low and middle income countries is also a very significant focus for him. So thank you very much, Dr. Moreira, for talking to us.
Thank you for the introduction or reintroduction, and then thank you for the invitation to participate. Hopefully what we'll cover in the next 30 minutes or so will complement a lot of what Dr. Qaddoumi was mentioning, and hopefully we address all the things that he mentioned I would talk about. So these are the three main themes that we'll cover. A general concept of pediatric neuro-oncology care across the world, general concept of workforce and education, and then an introduction to some of the educational efforts that we have at St. Jude Global, specifically going over a course that we ran a couple of years ago and that we are just rerunning as of January of this year. And I saw in the audience at least 3 people that participated in the last course, including 2 fantastic neurosurgeons, Dani Campos from Peru and Luis Arredondo from Mexico. So we know, based on population-based cancer registry data, that over the past 40, 50 years that the outcome of pediatric CNS tumors have improved, and this is probably linked to better radiologic infrastructure, better pathology, better neurosurgical capacity, and also the optimization of adjuvant therapy like radiotherapy and chemotherapy. And these are 2 examples based from SEER data, medulloblastoma and ependymoma. We see about a 30% increase in net survival at 5 years. And then when we read textbooks, we frequently hear this idea of pediatric CNS tumors are the second most common cancer. And this is really the experience from high-income countries. But if we look back at population-based cancer registry data from across the world, this is actually true. And CNS tumors represent about 20% of the new cancer cases in children, either 0 to 14 or 0 to 19. And you see in this kind of purplish color, the burden of newly diagnosed CNS tumors. And then if we think about not just the incidence, but what is the burden of children with CNS tumors worldwide, we anticipate that every year, anywhere between 30 and 40,000 children are diagnosed. But unfortunately, about 50% of those will not survive their disease. And if we look at these figures, and this is data from GlobalCan and the Global Burden of Disease studies, as expected, the burden of both incident cases and death is skewed heavily towards low and middle income country, as is the general population, but we see a marked higher rate of deaths in low and middle income countries. Returning to the concept of incidence, if we segregate the countries across the world in the World Bank tiers, those 4 tiers that exist, high income, upper middle, lower middle income, and low income, we see that the incidence is significantly lower in low and middle income countries, with really a positive data in low income countries. This is based on cancer registries, which in low income countries are present only about 10 to 15% of countries. And the other thing important to note is the proportion of CNS tumor to the total burden of childhood cancer is also lower. So there's obviously barriers in terms of diagnostic capacity, but also registration practices. It's unlikely that this is due to biologic consideration, although competing diseases like infectious disease could be also an important factor to consider. Then we always return to this concept of LMICs versus high-income countries, mainly because there's a very close correlation of the GNI or the GDP of a country with how much a country spends on health. So this is a nice study from the Lancet from about 8 years ago that goes over some of these factors more in depth. And when we think about pediatric CNS tumors, it's obviously a complicated universe to dissect. I think Dr. Qaddoumi, Dr. Buffet alluded to a lot of these concepts. Obviously, if we think of this ecological model, if we start off in the left, a child will eventually develop symptoms from their brain tumor, but they have to be engaged in the healthcare system or the health system. So they have to be evaluated by that first contact physician, that first contact nurse practitioner, nurse, whoever that may be. And there has to be that big step in terms of suspicion that the symptoms are secondary to a brain tumor. Then once that happens, there has to be the capacity to actually diagnose it. That is dependent on systems of referral and counter-referral, availability of diagnostic services. If a biopsy or tissue diagnosis is required, then that has to be available. And then obviously all this dependent on infrastructure resources. Once you have that diagnosis, which will hopefully be correct, then the patient has to have access to the correct treatment. This is obviously in pediatric neuro-oncology, access to neurosurgical capacity, radiotherapy if it is warranted, and then chemotherapy, not just any chemotherapy drugs, but the correct one with the adequate quality. And that will lead hopefully to not just survival, but good quality of life. And that is also dependent on the availability of supportive care. So this is obviously a complicated element and a complicated disease course, obviously all within the realm of availability of workforce, them being having the correct skills, knowledge, and competencies, having the adequate communication, and also ultimately having quality care at the essence. So then we try to dissect some of these things in terms of diagnosis and treatment. We see, as we have mentioned with incidence, there's massive disparities in terms of access to services. This is data from a couple of years ago looking at only the OECD countries, and we see a marked variability and availability of advanced imaging like MRIs on the left or CT scanners on the right, anywhere from about a 20-fold difference for MRIs to almost a 30-fold difference for CT scanners, anywhere comparing Mexico to the frequency in Japan. And then, as is well known to this audience, the availability of neurosurgeons and specifically pediatric neurosurgeons is a big barrier for quality care. And we know that there is an inverse relationship between the number of procedures done by a surgeon and the mortality rate. And that was published a couple of years ago. And then specifically for pediatric CNS tumors, the reported rate of gross total resections varies widely based on the available literature. This is obviously skewed towards upper middle income countries and probably more positive outcomes, but obviously linked to experience as well. And we see a lot of the same things also for pathology, market variability in terms of access to pathologists, but then there's also the question about infrastructure. What are the availability of basic stains, immunohistochemistry, and in our modern world, what is the availability of molecular tests as well? Radiotherapy is a big barrier to care. On the left is a figure from the Lancet Commission on Radiotherapy, where we see that countries in Central Africa have no access to radiotherapy. This is a couple of years old, but unlikely to have changed significantly, and that is availability, just the infrastructure, but then there's the question about quality of as well. And there's a report from Pediatric Blood and Cancer that described deviations of delivery of radiotherapy in one country in Central America. So if we go back to this, obviously a lot of different factors that are complicated, and really, to be honest with you, for the most part, outside the realm of clinicians. That doesn't mean we can't influence them, which is why this is very important. Dr. Buffet mentioned it in his talk, and this is a global initiative of childhood cancer. This is a WHO initiative funded by St. Jude, and there were many a discussion, but I was lucky to have been part of the discussion that picked the 6 index cancers, and we have 6 cancers that represent the comprehensive nature of pediatric cancer care, and low-grade glioma was proposed, because of its reliance on having a connected health system, systems of reference and counter-reference, the availability of multidisciplinary specialists like neurosurgeons, radiologists, pathologists, oncologists, but also rehabilitation services, physical therapy. And so that is why this WHO initiative has access to pressuring governments for investment. And at the end of the day, this initiative is seeking to save 1 million lives by 2030 by increasing the survival rate of these pediatric cancers to 60% by that year. So when we think about health systems and how we can link care and available services, health systems are frequently divided into these 6 building blocks. And this is a publication from more than 10 years ago, but still very relevant. And when we think about the patient that we have in front of us, if we're in the OR, we're providing post-operative care, we frequently are in the realm of service delivery. And that is about availability of OR time, of OR infrastructure, of systems of reference, and that kind of direct patient-provider interface. But there are 5 other things that are very relevant. This is where we typically are in the patient care realm, but we have to think about the workforce. This is one of the 6 building blocks to a functioning health system. And when we think about the importance of the health workforce, there was a publication from the WHO, and I love the title. It's very clear, but it is very poignant, that there is a universal truth: no health without a workforce. And when we think about the workforce, it's not just about number. It's about the right number of specialists, and that includes a multidisciplinary care, but where they are also distributed. Are they all centered in one single referral tertiary center or 4th level center in the capital, and they're all concentrated there? That is very different as a more homogeneous distribution across the country. So those talk about availability, number, and accessibility, which is distribution. And then relevant more towards the realm of education is, what is their training like? Do they have the knowledge and the skills, the competencies to provide high quality care? And that relates to quality and acceptability. And when we talk about education, ultimately, through educational programs, through educational initiatives, the end goal of an education system in medicine is to provide the population with the health professionals with the adequate competencies. Obviously, there's links in different realms, both at the population level, but also at the labor market. And this is something that we cannot forget when we are engaged in trainee programs, right? There's not much point in training hundreds of pediatric oncologists if the job market is saturated and they will not be able to practice their newly acquired skills. So we have to remember what is the population needs and addressing those through our educational system. So when we think about educational intervention for pediatric neuro-oncology, these are some very general thoughts. There's obviously the realm of clinical management, and here I think we have to think about risk-adapted care and keeping at the essence the idea of curing the curable, right? And optimizing our resources in that way. And also resource-adapted care, right? We don't want to provide services that provide care that is outside of the realm of the available resources in terms of supportive care, for example. Here, this is more towards looking to the future, is how can we integrate novel technologies, right? Dr. Cohen described very nicely how the field has transformed a little bit ago, and how can we use that information to leapfrog, for example. An example that I frequently use is, for example, Wnt medulloblastomas, right? They represent a fraction of medulloblastomas, but they have a very good prognosis. So can we leapfrog using molecular characterization and de-intensifying therapy if we identify those prospectively? So this is an idea that we can think about as well. Like Dr. Qaddoumi just mentioned, how can we optimize the clinical management for the detection of brain tumors? And this is both for non-specialists like general physicians, like pediatricians, nurse practitioners, community health workers, and also specialists like ophthalmologists or GI specialists who are performing scopes on people with recurrent MSF. Outside of the realm of clinical care, but this is in the realm of more global and public health, is what are the skills needed to perform research? We need to know what is our current status so we can identify valuable interventions and prioritize those interventions. Also thinking about quality improvement skills and identifying those strategies and monitoring those over time. And then a more novel area of research is implementation science. And this is really, how do you need to modify and adapt interventions that have a strong evidence base in different contexts? Specific for pediatric neuro-oncology, always important to mention that this is obviously a team sport and multidisciplinary care is required for these patients. And here is where team-based learning can be a way to address that. This is a way that we can galvanize teams and create more consolidated team dynamics and better communications. And always in any intervention, always key to have monitoring and feedback strategy. That way we know that our evaluation is defined at the beginning, so we can see if our interventions are actually worthwhile and they can be tweaked over time. In terms of possibilities of realms of education intervention, there's always the clinical training programs like fellowships, like residency programs, and there's a nice amount of literature specifically for pediatric neurosurgery in the LMIC context, and these are some publications related to that. And then there's also this possibility of telehealth and international partnerships, and both Dr. Qaddoumi and Dr. Buffet mentioned using this as significant leverage as a mechanism for training and education. Here are a couple of papers describing the massive possibilities of this, and over the past 2 years, we have seen how teleconferencing and Zoom and WebEx is a massive tool to be leveraged for communication and transcontinental care. And then going a little bit into the St. Jude global programs, our educational initiative is key to the global health intervention that is born out of St. Jude, and it is coined as the St. Jude Global Academy. There are different educational opportunities with two main buckets. One is the Global Scholars Program, which is basically a Master's in Science, which is a partnership with the newly launched St. Jude Graduate School of Sciences, and then the Global Professional Education Program, which has different work streams, and I will touch on distance learning very briefly, and then training seminars. Naren mentioned at the beginning of Dr. Qaddoumi's talk the visitors program that unfortunately has been disbanded, but it has been to some degree recreated in this training seminar approach, which we think is even more valuable and is more structured. And I'll go over a course that we ran a couple of years ago. So when we think, and this is a little bit of educational theory, when we think about the hierarchy of medical education or medical education interventions, there's the level of cognitive impact. You know something, you know that low-grade gliomas are the most common tumors in children. That is valuable, but even more important is what do you do with that information? What is your behavior based on the knowledge that you have? And this is a big step, right? And this is where clinical experience and clinical expertise comes into play. But that is really what we're trying to get at when we have an educational intervention, not just people knowing more, but they actually apply that in their clinical practice. And that is where changing behavior is what we want to achieve with a lot of our educational intervention, at least from the St. Jude side. Yes, we want to concentrate on providing opportunities for advancing knowledge and skills. Hopefully that builds on clinical competencies. But ultimately, the next step is, how does that change behavior? Ultimately, and this is indirect and this is down the line, but how does that change the outcome of the patients that people are seeing? And that is really what we're trying to get at. And that is really that linkage of educational programs with the needs of the population. So we'll talk about these two things briefly. Distance learning, we know access to educational content is key. And that is obviously during formal training programs, but also just like this forum, professional development and continued medical education over time. Access to information is key for knowledge, especially more recently in our field where everything is so dynamic and there's new classifications coming out, there's new diseases being described, novel treatment strategies. So this is key. And this is where distance learning can come into play. Obviously, an increasing amount of online resources exist, and that these are specific to neurosurgery, pediatric oncology, and these are in the form of written content, I think more relevant for surgical specialties, video libraries, and also an area that is a little bit more novel, simulation-based opportunities as well. At St. Jude, we house Cure for Kids, which is a distance learning platform that has been around for about 20 years or so. We have 60,000 registered users, closer to 10,000 users that are active. We have about 50,000 content views per year, and we house also a integrated meeting platform, and we host about 2,000 meetings per year. Over the past almost 20 years, we've had about 1.9 million views to our Cure for Kids website, and this is specific for pediatric oncology. So there is some content for pediatric neuro-oncology, and with our fortune of having Dr. Booth joining us, we hope that more content will be relevant for pediatric neurosurgery. And this is a map of where our users are, heavily skewed towards the Americas. And then I'll go over this training seminar experience that we have from a couple of years ago. And this was an idea that Dr. Qaddoumi had. And then when I joined St. Jude, together we worked on how to best optimize this educational opportunity. So the core concept that we had for this course was that it would be hybrid or blended, that it would have an online component that would be leveraging Cure for Kids, but also have an in-person component, which is really more about that direct interface, consolidating the knowledge required on the online component. We wanted centers to participate as teams, kind of understanding that multidisciplinary teams are the key towards a successful pediatric brain tumor program. And then we wanted to concentrate on centers with the capacity to treat CNS tumors. This was knowing that centers, for example, in low-income countries may not have access to radiotherapy, for example. And then the other thing that we wanted to do is define the curriculum in a systematic way. When we want to come up with a course, usually as physician, as medical educator, we typically want to jump to the content. We're going to talk about ependymoma, we want to talk about medulloblastomas or hygrogliomas, but that is, even though historically done and still done currently, that is not the best way to optimize medical education intervention. There's a little bit of a systematic approach to it. This is the model proposed by David Kern out of Johns Hopkins. And it really includes a very logical step. There isn't anything massively groundbreaking, but it's really based on that idea from the Lancet Commission on Medical Oncology. What are you trying to achieve? What is the basic population need that you're trying to achieve? And what are the needs of the target learners or the target participants? And this is in the realm of pediatric neuro-oncology, where we don't have much data in terms of service capacity. These are two papers in the last 10 years or so that described in some way objective measures of brain tumor service capacity in LMICs, a paper that Dr. Qaddoumi led and the paper that Dr. Finley led, and that was based in Paraguay. So what we tried to do was to design a comprehensive assessment of both neuro-oncology capacity, but also educational goals. So we designed a survey that had about 100 questions, identifying elements of these 11 domains that looked at health systems, basically the system of reference, encounter, referral, workforce availability, imaging infrastructure, pathology, neurosurgery infrastructure, medical infrastructure, which is more related to access to chemotherapy agents, radiotherapy, the multidisciplinary dynamic as a marker of care, identifying how CNS tumors are treated, but also looking at patient outcomes. Specific for learners, what were their educational goals? So based on those 11 domains, we sent out this survey to 24 centers across the globe, and within about a week to 10 days, we actually had answers from all 24 sites. These sites saw about 50 new brain tumors per year, and this is based on 19 out of 24 have an actual hospital-based cancer registry. When we asked them about predicted outcome of pediatric brain tumors. There's a variability anywhere from 0 to 19 to 60 to 80%, and that is a frequency in that histogram on the right. And then if we compile this data and distill it, what we found out was that centers had the necessary elements to treat, and this was skewed towards middle-income countries. So they had workforce, they had medications, and they had infrastructure, neurosurgery, radiotherapy. And when we looked at barriers to care, delays and abandonment was the most frequent one. We also identified a low estimated gross total resection rate at just about 2/3. And then the other thing is poor communication between teams, the inexistence of tumor boards. When we asked about possible solutions, communication, collaboration, and education were the three most commonly cited elements. And then when we asked about education goals, it was more about disease-specific topics, learning about medulloblastoma or DIPG. This is obviously, in terms of solutions, slightly skewed because we were asking these questions in the context of the possible education intervention. So I think we have to take these answers with a little bit of a grain of salt. So based on that survey, we identified themes, we defined the content, and we finally created the content. These were the 5 themes that we identified: the current landscape of pediatric cancer care. This was talking about burden estimations, the importance of cancer registries, and then tools of change, which is kind of general concept of global and public health. Diagnosis and treatment of the different types of brain tumors, comprehensive care, which is basically this idea of multidisciplinary care and cohesive and effective teams, research and quality improvement, which is basically skills that we thought were relevant to both identify the current context, the current outcomes, and prioritize intervention for the future, and the ability to measure those over time. So this course started in 2018. We had that needs assessment. We're going down that figure on the left, the 5 themes that we mentioned, and then we had a 9-week course held on Cure for Kids, and we had 8 institutions from 8 countries participate. The countries in red in the map on the top right are the countries that were included. We had 36 participants that completed the course, and the course, included pre-recorded lectures as kind of theoretical content. We had important, valuable readings at that time. The 2016 WHO classification, for example, was one of those. Discussion forums were both online in an asynchronous way, but also online discussion, talking about cases, talking about barriers to care. And then each team had to develop a research project. And this was a mechanism that they could use, put into effect some of the newly gained skills in research and quality improvement, but also a way to galvanize those teams. And then based on those 36 participants, we invited 20 participants to come to Memphis to St. Jude to have a 7-day workshop. And there 7 institutions from 7 countries were represented. And that included all the subspecialties that you see depicted on the right. And this experience we published in Cancer last year. And when we were thinking about evaluation of this course, we went back to some of the basic concept of medical education and evaluating interventions. There's a 4-tiered structure proposed by Kirkpatrick. The first and the most basic being reaction is, do you like it? Which is important, but ultimately not the most advanced way of evaluating intervention. Learning is knowledge. And then what we wanted to gear more of this intervention tool was behavior. Results is hard to address when we are talking about clinical outcomes. So these are some of the results that we had. We had an improvement in knowledge in the 5 categories that you see on the left, and this is based on pre and post test, statistically significantly higher level of knowledge. And then in terms of behavior, and that's the figure on the right, and this is self-perceived behavior, we saw a positive impact of this course as well. As mentioned before, the objective patient-based results were not captured, but as I'll mention in a second, we have, based on this course, now have mechanisms to do that. And that is because, from a very honest perspective, this course was more about everybody learning from each other. And this is both from the St. Jude side that were more the facilitators, but also every expert that came from across the world had a lot of valuable insight to provide to the colleagues from across the world. So 2 of the centers started multidisciplinary tumor boards for pediatric CNS tumors as a result of this course and their project. And then importantly, the team that came to Memphis in a very organic way came together as a team and created this GAPNO group, which is the Global Alliance for Pediatric Neuro-oncology. And for the past 2 years, and this is since the end of the course, or almost 3 years now, we have had continued engagement. We have a couple of publications out of it. That first one at the top came out in JCO Global Oncology, which was basically a description of the workshop and a lot of the discussion that we had there. And that was a description of that. And then each of the groups have had some publications and presentations at international forums. So that was the experience from 2018, 2019. And then we currently are running the course, and we're just about week 7 of 9 on the online component. And we did an international announcement for this course in the late summer, and we had applications from 60 institutions from across the world. But we had to select 14 countries, and those 14 countries represent 14 institutions, sorry, and those represent 13 countries from across the world. So we have 3 countries from the Americas, Mexico, Guatemala, and Honduras, a representation from 3 countries in Africa, Egypt, Ghana, South Africa, 1 Eastern European country in Belarus, and then we have a lot of representation from the Middle East and Asia, as you see in the map. Syria, Kazakhstan, China, Vietnam. We have 2 centers from Pakistan, and then we also have Indonesia as well. So this is a fantastic group. It's a very energetic group, and we are very excited to be running the second cohort and hoping to build experience from that first one that we ran a couple of years ago. So kind of a general concept, at least from my side in terms of conclusions. It's not just about the educational content, but providing the right content for the right people. And this is where kind of that systematic approach that we engaged on, I think, was very valuable. And I think the other point is team-based learning is very important for pediatric neuro-oncology. It's a mechanism to galvanize multidisciplinary teams, to bring them together, be more efficient, have better communication. And then when we think about any intervention, metrics of impact are key. And this is in the realm of some of what Dr. Qaddoumi was mentioned. How do you engage those primary care providers? How do you engage them so they can refer in the correct frequency, perform imaging in the correct frequency? This is a hard thing. And at least in our world of pediatric oncology, this is in the context where model data estimates that 50% of the children who develop cancer are never diagnosed. So this is a realm that we cannot forget. We see the patients that are diagnosed in front of us as pediatric neuro-oncologists, but we cannot forget that 50% never make it to a diagnosis. And that's something that is, at least from our field, very worrisome. So I think that's, that was my talk. Thank you for your attention. Happy to answer any questions that may have come up.
Thank you very much, Dr. Moreira. I'm just looking through the list to see if we've got any particular questions that have come up. I don't see any. My question to you then is, and the comment that Dr. Qaddoumi came up before, was that you've got a cohort of people coming through now who are going to potentially act as ambassadors. Have you got any mechanism whereby they can then be assisted in the way that they disseminate the information in their own centers?
That's a really important element. This is obviously a very small group of experts. Sorry, one second. A toddler barging in. But yeah, we have to understand that at least our idea was that the people who participate in our course be local champions, right? That they take it upon themselves to engage the primary care providers, to engage the other oncologists, engage the other neurosurgeons. So it isn't just a small drop in the ocean, and that we can, to some degree, make these education opportunities scalable to some degree. Our footprint, whoever may be small if we think about it in individual partnerships, but if we make it with scalability in the essence, this is a way that we can kind of make this ripple effect. And I think the other thing is reaching out to other specialties, I think, is key when we think about pediatric brain tumors.
Absolutely. I mean, it's a wonderful initiative, and I'm sure it will be very successful. It already has been. I don't see anybody with any more questions. Is there anybody who'd like to ask any particular questions to Dr. Moreira?
Just a comment. I think I'm very impressed with the program that you have. The listserv started what we call the Global Varsity of Pediatric Neurosurgery. This is an online course. The idea is for 1 year course. Once again, we have got 55 world-class pediatric neurosurgeons, and in the first year we have about 90 students, and so I think with the technology and the fact that it's not so expensive, I think the main thing is the assets of the people who teach. I think there's a positive future. Thanks.
Excellent comment. Thank you. Okay, so I'm going to draw this session to a close, if that's permissible. Naren, are you going to take over for the next bit or not?
Please. Thank you very much, Dr. Lois. That was fantastic sharing with very, very important lectures. So now we come to the two lectures. First of all, first lecture is from Dr. George Jallo. Dr. George Jallo is Professor of Pediatric Neurosurgery at Johns Hopkins Old Children's Hospital in St. Petersburg. He's also the medical director, the chief physician there, and also vice dean there, and also he's the chair of the Neuroprotection Institute at the Old Children's Hospital. But me and Dr. Jallo go way, way back when he was a fellow with Dr. Epstein, and I was just passed out of medical school. Came out of Stoke Mandeville, and I was in Cambridge when I decided to start a journal called Annals of Neurosurgery. The Annals of Neurosurgery was meant to be a journal where I published the posters, but Dr. Jallo then kindly sent me a paper of Dr. Epstein on ependymoma. So I thought, well, I'm an opportunist, so rather than publishing posters, let's publish with that paper. It really started the Annals of Neurosurgery, had a great run, and he will have it again. And I have worked with Dr. Jallo for the last 20 years or more now, and it's a great privilege and honor to have worked with him. And he's going to talk to us about complex cases he has managed and what he has learned or what we could learn. Thank you, Dr. Jallo.
Thanks, Naren. And I can't believe it's been so many years that we've known each other throughout my career and your career. It's just been a privilege to see you grow up, as we call it, and see what you've done with the Annals of Neurosurgery, to the listserv, to really these webinars and these courses. This 3-day course has just been phenomenal. And as we bring it to a close in these two lectures, I'll try to share some of my experiences with some complex cases. I think the first one is a recent case. Actually, a recent case I took care of several years ago, and just some lessons learned. This was a 5-year-old boy that presented with focal, really started out with some, what would be funny sensations on one side, and then on the left side, then would become with some focal motor movements on that side, and then occasionally generalize. He had an MRI that showed the parietal lesion, and I'll show that. And there was diagnosed. So it was diagnosed promptly. We can't argue with that, unlike what we heard earlier this morning. And there was discussion whether this was a focal cortical dysplasia versus a neoplasm, and appropriately was started on single agent anticonvulsant therapy. But within 18 months, he was up to 3 anticonvulsants and still having seizures. And he was having 4 to 6 seizures a month, all partial complex. He would have an occasional generalized a grand mal seizure, which without provocation. However, those were, otherwise he was doing well in school. But here's the films. So this was the scan, the first scan at time of diagnosis. You can see that on the T2 sequences, there is a lesion in the post-central parietal lobule there. And on the axials, you can see the central sulcus. So it is emanating most likely just behind the motor strip, coming up to the midline and going deep. Here's the scan in August of 2015, almost about 9 months after the initial scan, as he was getting more therapy, more treatment. Here are the axial images. And then probably about another 6 months later in February of 2016. And I think, here are the axial images. And this is the summary slide. It's interesting. And the reason I share this as a complex case is I think, here's the first scan on the sagittal T2s. It did not enhance, so I didn't bother to share the enhanced images. But when you look at this, this was the initial scan on the far left. The middle was the intermediate scan about, probably 9 months later. And then about probably 14 to 16 months later was the most recent scan on the far right. And as you can see that clearly there's been progression of that tumor. What was felt to be cortical dysplasia cannot be cortical dysplasia because it's growing. And I think the lesson learned here is, as this child was being managed at a very good center with another neurosurgeon and another neurology team, what they were doing was this child was getting scans every 3 months appropriately, but they were comparing the scans, the most recent MR to the immediate previous scan, and they would say, oh, very subtle change or very little growth, if any, when you compared them on a 3-month interval scan. But when you look at this summary slide here, you can clearly see within 18 months from the initial scan to the most recent study there's been significant progression of the tumor. And the question comes up, what would one recommend? What are your recommendations? Should we continue to observe? Should we continue to treat the refractory seizures? He's on 3 anti-seizure medications. Or if we do surgery, should we do a biopsy? Should we do a resection? If we're going to do maximal safe resection, are there any tricks that one should utilize? How close is this to motor cortex? Or how is this in relation to eloquent cortex that we should worry about? And I think that's the discussion that came up when I met the family. And I think it's important to get just to get thoughts as to does anyone have thoughts? Would they continue just to keep trying the seizures? I mean, as the literature supports, if you're on 3 seizure medications and it's not stopping the seizures, still having 4 to 6 seizures a month, you're unlikely to get control of those seizures. And then should you just do a biopsy knowing that this is now more likely to be a neoplasm rather than a focal cortical dysplasia. And what
George, if I can answer your comment,
Sure.
I'm happy for. I hope you are okay for other.
Oh yeah, I'd
people to
love it.
discuss. I think rather than being a lecture, people can come in. The thing is that Professor Dufu keeps very vehemently saying this idea of looking at a 2D scans and trying to see. I mean, here you can see actually the sizes have obviously got larger, but even when the sizes don't appear so much larger on a 2D scan, when you look at the volume, because there's even a 1 millimeter increase in a 2D scan, in a 3D structure, the volume has increased quite largely. Is it time that we actually go for a 3D assessment of these tumors that we observe? But that's one point. But anyone else that wants to come in, please come in. Thanks. Dr. Boop, do you have any thoughts, comments?
Well, I'll make two comments. One is when we see someone who has a lesion like this, you really have three options. One is you can observe it like they did, you can biopsy it, or you can resect it. And remember, when you do a biopsy, then it takes you back to one of the other two options. You're either going to continue to observe it or you're going to resect it. There's scalloping of the inner table, so that's a radiographic sign of a benign tumor. But in a child who's on 3 anticonvulsants, they're not going to be able to learn well on that much medication. The seizures are only going to get worse as the neoplasm grows. So I don't favor a biopsy in situations like this.
Thanks, Ray. And no, I think both points are true. I think, ideally 3D imaging is better because you'll get a true volume sense of growth and correct. I mean, I think observing, they've observed it and it's continued to grow. So clearly it's not a cortical dysplasia. I mean, I think we could have clearly noted that with the scalloping and stuff. The other is as Dr. Boot mentions, he's got refractory epilepsy on 3 medications. It is not going to get better unless something's done. And the question one can consider is, do you do an oncological surgery or should you do an epilepsy surgery in terms of the operation? I think there's a question, Naren, there, please. I think, I'm not sure if someone raised their hand. I couldn't see that, but if you please free to chime in, I'll tell you what I recommended when I met this child. So I actually, Rick, I agree with you. Rather than, my assumption was this was a low-grade tumor, and my recommendation to the family was surgery to remove the tumor. Although it was close to the motor cortex, using neurophysiological mapping and intraoperative monitoring, I thought we could remove this safely. Did I consider an awake craniotomy? No, I think he was too young to do an awake craniotomy. So really relied on the neurophysiological mapping during the resection. I did not plan. I wanted an oncological operation rather than an epilepsy operation. I did not plan on putting in grids or depth electrodes prior because I felt that his seizure semiology was from this, and felt that if we were able to remove this completely, we would get control of his seizures. Any other thoughts from the audience? So, and that's what we elected to do. And you can see here the post-operative films, and you can see that, by working within the tumor, we essentially were able to remove, I'd say we got a near total resection. There's probably some small residual down at the cingulate gyrus down there. And he woke with no deficits. And you can see the post-op MR. We, over the ensuing 6 months, weaned him off, actually weaned him very rapidly off the 3 medications down to 1. and within a year had him off all seizure medications, and he's been seizure free. The histology returned as a DNT, disseminoplastic neuroepithelial tumor at that time. And he's had no further adjuvant treatment, and that small residual has essentially almost involuted completely at the inferior pole of the resection bed. So, for me, what were the lessons learned? When I look at this case, I can understand why his outside treating team was hesitant and had recommended observation. But at the same time, I think, one should recognize that when you do comparison films, it's probably wise not to compare to the immediate scan prior if it's done within 3 months, but to go back and compare to prior films, maybe a year or two in the past, to truly get a sense of growth of these tumors. And the other lesson learned, I think, for this complex case was, just because it may be an eloquent cortex, you really should consider intervention when it does start to interfere with a child's life or some form of treatment. Because, as Dr. Boot mentioned, if a child's having 4 to 6 seizures a month on 3 seizure medications, there's no way they're going to be functional in school or at home. Any other thoughts on this case?
Dr. Jallo, could you just explain to us why you didn't get any deficit? Because this was just tumor that you removed and the motor cortex was not affected, or the function was already moved around?
So exactly, Darren. This tumor came up straight to the surface, and when you opened up the craniotomy, opened up the dura, you can see that the brain itself was involved with tumor. And by staying within the tumor, and I'll apologize, you can see that if you stayed within this tumor, this was all tumor, and that normal brain tissue was displaced. The motor cortex was being displaced anteriorly, and I think the sensory cortex was probably displaced posteriorly and laterally. So at the end of the resection, he woke up with no new deficits whatsoever. And I think you can, as evident on this postoperative scan, you can see that the gyri are all there, and this is just, here's the cavity for where the tumor was, and it had displaced the sensory cortex. Can you see my arrow? I don't know if you can see that.
That's kind of, yeah.
Yep. Sensory cortex and the motor cortex was just at the end, just anterior to the tumor.
It's a question from Dr. Gupta, Uday Gupta. Did you get DTI, he asks?
Yes, we did prior to surgery, and I apologize for not sharing that. It showed that the motor cortical spinal tracts were anterior and deep.
Thanks.
Okay, I'm going to share the next case. I'm going to skip this case. Here's a case that I just saw. I'd say this in the COVID era. And that's why it was complex was, I think, one, I'll share the history. An 11-month-old that was, I think, history was the guardian or the mother, really the aunt, was taking care of him, and he slipped off the bed and fell less than 2 feet onto the ground. Was crying, so the guardian brought him to an outside emergency room. There's some soft tissue swelling, so they did a CAT scan, and here's the CAT scan. It was interpreted as blood in the ventricle, and they felt that this was also blood, so they elected to transfer him to our center. And the diagnosis was a traumatic intraventricular hemorrhage. You can also see that there's a component of ventriculomegaly. His Glasgow Coma Scale was 15 upon transfer. The MRI the next day, here's the T2 MRI, the MRI with contrast. just because, immediately said this is not, there might be a little blood there, but it's not trauma. It's not all blood. There's an underlying lesion, and clearly there's an intraventricular tumor that enhances with the hydrocephalus and the ventriculomegaly. And you can see it on the coronal T2s and the sagittals without contrast. So this was on hospital day 1 at our institution, and his COVID test comes back that he's positive for COVID, and he's also febrile. So he's a symptomatic child with COVID-19, and for us, the lessons I learned is, do you operate on someone that's got a brain tumor, hydrocephalus, and COVID? We were planning on surgery, but after discussion saying, this is most likely, I think on the differential, is a choroid plexus papilloma that he's probably had for some time. We could electively do this if he stays stable in several weeks' time, in 2 weeks' time after he convalesces from his coronavirus, and that we would just watch him in the hospital, given that he had the respiratory infection. And as unfortunately, 3 days while he's in the hospital, he has a seizure, some seizure-like activity. They do the EEG, get the CAT scan. He really doesn't have any spikes, but you can see that the ventricles are getting bigger, slightly larger than upon admission. And then there's no evidence that there's any intratumoral further hemorrhage from the tumor or anything like that. And I think the discussion, lesson learned here is, what do you do? Do you address the hydrocephalus? Do you temporize the hydrocephalus, or do you treat the tumor at the same time? And I think we had a long discussion amongst the team and felt that he is symptomatic at this point. He came in asymptomatic from the tumor, but symptomatic from COVID. Although he is symptomatic from COVID with a respiratory infection, he's clearly become symptomatic with increasing ventricles and the tumor. And we elected to take him to the operating room the next day. And at surgery, the decision was, do I approach the tumor, remove the tumor, and leave an external ventricular drain at the same time in the resection bed? Or do I place an external ventricular drain in the frontal region and then address the tumor via a superior parietal approach? I think Dr. Moreira discussed the approaches to trigonal choroid plexus papillomas yesterday. Any discussion? I mean, I'll share what we did and the lessons I learned from this case.
Sure. And Professor Grotenhuis, do you have any thoughts? How would you?
Unmute myself. What?
Yeah. What would you do? What would you do, Prof?
I would approach the tumor, not doing first a kind of external diversion. Actually, here I would take advantage of the somewhat larger size of the ventricles, but it is urgent because you see there is no peripheral salt size visible, so there is pressure going out of this, but it is a rather straightforward approach, transcortical to this ventricle system. So I would go for the tumor. I mean, it's a benign lesion. Usually, it is not the chance that this is in this child a carcinoma on this image is rather bleak. So I think it is very straightforward to get a total removal of this lesion. That's you say seizure-like activity. I would be very surprised if these are really seizures.
They were. So he was found to have an episode of, you know, of staring and, you know, by nursing. So he did have an EEG just to rule out the possible seizure. There were no seizures that were found on the EEG or spikes. You know, I think what we assumed had happened is that the ventricles getting bigger, there's the loss of gyri. I would assume it's a pressure phenomena. And I don't know, you know, what others recommended.
See sometimes if they are vomiting, these children quickly go into metabolic disturbances.
Yeah,
that is something that is very often overlooked by neurosurgeons. But this can easily happen. They quickly run into an hyponatremia. So this is also a possibility. I have seen it associated with tumors more in the third ventricle, but also with just enlarged ventricular system.
Yeah. Metabolically, he was fine on this day. So, you know, we did bring him to the operating room the following day. So, you know, between the CT and surgery was a day. You know, he stabilized after that. But given the ventricles were bigger, elected to put in a frontal, you know, positioned him that we would approach both at the same time. But elected put the EVD to have control of the hydrocephalus because, you know, just concerned that there's some raised intracranial pressure. And clearly, you know, we put the EVD, he was under a lot of pressure. We drained a little, you know, drained about 5 cc's just to decompress him a little before we did the transcortical superior approach.
Trying to collapse those ventricles. No, typically such a CT scan is made at 5 p.m. So so it is never done at 10:30 in the morning, so that you can maybe do it in the afternoon. It's typical. This would not be a night shift case to do. I fully agree with you. We had this adagio saying we don't want to have let the sun set or the sun rise over such cases. But I would assume if you do this the next morning, that's absolutely reasonable. But even then, I would probably not put in an EVD. No.
Okay. And yeah, I think the confounding factor for us was that he's COVID positive, and getting the OR, you know, team to you know, together and all the precautions necessary. So we did.
Are we really concerned with COVID in children? They are. I mean, COVID is now. I mean, it's of the 10 possible diagnoses that you present somebody now. It's COVID, really, which is ridiculous. I noticed that myself when I had some arrhythmia. I had necturia. I had swollen feet. I was short of breath. He said, "Short of breath? Oh, that could be COVID. So you have to go to a COVID." So, I mean, this is all.
Yeah, we
are really a little bit. You would not be concerned if this child would have a cold.
No, absolutely.
It's also a coronavirus. That's also a coronavirus. They are not very sick of it. They don't have pulmonary symptoms. They are not very ill. They have fever, yes. But that's so I agree with you because it's all COVID now. That also the personnel, the people in the OR, the anesthesia team, they want to protect themselves also. So that's absolutely fine. So you prepare the OR.
Correct. Yes.
George, can I just come back to you? In terms of, I have had 2 patients through my career, not personally, but in the departments I worked, when patients, I'm sure you have seen it as well, patients are reported as saying had epilepsy-like activity, and it's just like a pre-coning with a hydrocephalus, and usually in a patient with seizures. And my feeling is that the epileptic-like activity was, as you said, it's more like a pre-coning hydrocephalus with a cerebellar or brainstem reflex with a hand flapping. And I have seen 2 patients die when the nurses have called and said it's a epilepsy, and the registrar had just put on anti-epileptic and gone away, and then the patient dies. So my feeling is that I know I'm not as experienced as Dr. Groton-Hughes, but I would be keen to have a bit more control on that hydrocephalus overnight rather than leaving it for morning with that history.
No, it is really a reasonable thing to do. So it depends on your local possibilities and how quick you really can go. But the same is with posterior fossa tumors. We often discuss, should we do an ETV first or a shunt first? And then we see, I mean, the treatment is removal of the posterior fossa tumor, which we usually simply go ahead with. And that's the point. That's because this is the thing that will really help this kid in the further course. But George, would you say that's fully correct?
I think you're absolutely both. The treatment is removing the tumor, and it should treat the hydrocephalus and everything. But again, Naren, I think you can't stress it enough that the seizure. You gotta be careful with this. Where the nursing says it's seizure-like activity can really be a sign of raised intracranial pressure, and that's why I'm sharing this case, because I'll describe. So here's the post-operative MRI, and I did share what we did. You can see that there's the flare signal abnormality in the bilateral occipital lobes, and the surgery was uneventful. I mean, we put in the right frontal EVD, and then at the same positioning, we took out the tumor through the superior parietal lobule. And surgery was maybe an hour and 45 minutes. Blood loss was, I think, maybe 15 cc's, the time in the operating room, there's really nothing that was predictable in the operating room, because there's no hyper or hypotensive episodes, but you can see on these post-op MRs, and I apologize, I didn't share all of them, but the tumor's gone, but you can see the contrast, that there's signal, there's the flare signal change in bilateral occipital as well as in the cerebellum, with the enhancement in there, so the question is, the lesson for me that was learned, we look back at this case and said, what happened? And, could we have predicted that this was going to happen? Did he have an acute rise of his ICP during the operation? And I'm like, well, not really, because it was in, the EVD was put in immediately. That was the first thing that we put in before we even began the tumor.
Wow.
And here he is 9 months after surgery. You can see everything's, essentially he's recovered. He's done well. Eventually did require that EVD to be converted into a shunt, but otherwise he's done remarkably well. And that signal change has recovered. But clearly there was a ischemic injury in the cerebellum as well as in the occipital lobes, that I think we have to assume was probably from raised intracranial pressure. The only other thing that we could think of was, could this be a COVID vasculitis? But I think that's stretching it, and I think you can't say that, right?
No, absolutely. I mean, this is looking for something. This. And I agree now with Naren that to say, so this child was very close to coning, just herniate, and these are the kids that we were all afraid with shunts, that they play and die. So that's all. And I think every neurosurgeon, when your career is long enough, have seen those cases, which are just devastating, just terrible to because it is preventable. But this is ischemia. This is actually also, especially this in the cerebellum, that was described as the Arnold syndrome. So this is absolutely high pressure. And to that, for sure.
Now, I think the lesson learned here is, for me anyway, was, especially these kids with COVID. So they're put in yes, he's in the ICU, but he's in isolation, essentially. They are not being monitored, and, we're not doing a good job monitoring these children as well as we would have. And, the other thing is, when he came in with COVID and upper respiratory infection, we elected to postpone surgery for some time. rather than address the tumor. And it was only when he presented with that that episode of raised ICP that we brought him to the operating room. So I think the lesson learned is that yes, these tumors, brain tumors, although some can be benign and elective, they still can present in an acute presentation and lead to death. The pathology turned out as predicted, chorioplexus papilloma, completely benign, not even a carcinoma.
But why did this child have a hydrocephalus?
So I think, personally, I think there was a little blood in there, and somehow he might have had that might have occluded the pathways. I can't explain it any other way.
No.
I don't know if you saw the initial CAT scan.
Yeah, I saw it. It definitely became in as a trauma, assumed trauma, a fall from a bed. But at this age, I assume his fontanelle was still open.
Yeah, it was all open, and it was, it was
small, as you can see, but open.
Yep.
But that never helps. That this is something I teach my residents to say. Even with an open fontanelle, you can have raised intracranial pressure.
Correct.
Fontanelle is not an escape mechanism for the brain. That's this is true that maybe there is, because it is some more than hyperintensity than you would expect on a non-enhanced scan. So yes, that could be interesting case. Absolutely interesting case.
That was one of our cases during COVID. So I mean, I think it's very interesting.
You brought the COVID into it.
George, can I just bring in Mr. Shalindra from Oxford? Yeah. Mr. Shalindra, do you have any comment there?
Yeah, great case, George. I think I have seen this finding, and we presented it. It's posterior reversible ischemic encephalopathy happens post acute hydrocephalus, where there's tightness in the brain and you decompress it, and then basically it causes what they call a PRES in it's more common for the neurologists to look at that. They get hypertensive, and it's almost similar to what we call it as a reverse coning type picture with the cerebellum and the posterior occipital ischemic laminar necrosis type picture.
So my thoughts were with PRES were that you would have, it was a hypertensive crisis. They would have high blood pressure with it.
Not always the case, but this episode which you said that they were like epileptiform, like that could be one of those things which happen, and then you took the kid to the theater. So in between that period, it must have happened and reversed in a way.
Yeah, absolutely. Yeah, no, correct. I think that's, I think we agree that this is definitely from pressure phenomenon, not a vasculopathy from COVID, as people were alluding to. And we're fortunate enough to bring them to the operating room. Promptly.
I just meant that Dr. Jallo from Copenhagen has done some nice studies on pressure in very young children. And in infants, you can't rely on what we know as the Cushing reflex with hypertension or bradycardia. That will not happen.
Yeah.
So this is the difficulty, that in many cases this is true, but this is an 11-month-old. So that's so probably this seizure-like activity was indeed the preceding coning of that child, and not having any hypertension or bradycardia. You don't see the typical start of tachycardia, then hypertension, then bradycardia, and then finally blood pressure drop and cardiac arrest. That's not what you will see in infants.
Yeah, no.
And the other point is, you're absolutely right, George, that we don't do the full. As certainly I didn't do the full examination and monitoring of a patient I had with COVID in our PICU. They were nursed behind a vertical unit where the nurses were all masked up, and we were certainly I was talking over the phone to them, and it's I didn't go and look at the pupils, this and everything. It was all dependent on them. So certainly, in the COVID days, the COVID positive child, and COVID is hitting us quite badly. in Oxford or in England, there is that easy to miss things because we don't necessarily do all the examination which we probably should. Thanks.
Great.
Thanks, George. Cheers.
Thank you. Thank you. And I think I'll just finish it with this last case. This is a 9-year-old boy that presented with just some headaches and he presented in a hemiparesis, as seen here, right-sided hemiparesis. Here's a T1 without contrast, T2, as well as a T1 with contrast on the images. And there's the coronal and the sagittals. And the question is, I think, again, going back to, what are the options? I don't think observation, he is symptomatic, so observation's not an option. And the options are, should he undergo a needle biopsy and or surgery? And if one does surgery, what is the best approach for this? Open it up for any discussions there. So, after I think we had a discussion with the family and said, my goal would be the maximal, again, just debulking, trying to see how much we can remove, the corticospinal tracts. If you can see it, the internal capsule are all displaced medially on this tumor here, which is pretty much homogeneously enhancing and emanating and displace. You can see it on the coronal there with the corticospinal tracts. And there's several approaches. And I think, the controversy here is which approach. Do you want to go through, do you do a transcortical approach via the temporal lobe? Can you go down the frontal lobe? Do you want to do a split the Sylvian fissure to approach this? Or do you want to go subtemporal approach? The approach that I elected was really to do a transcortical approach with a tubular retractor, the brain path, to get in there and try to debulk as much of this tumor as safely possible. The diagnosis I had was I thought this was going to be a low-grade polycytic astrocytoma, given the long history as well as the imaging characteristics.
George, can I just get Professor Deopujari? Prof. Deopujari, how would you have?
George, can I have a look at the axial films? One of the things which where I decide to go for a radical excision or to do a navigation or stereotactic guided biopsy first is probably the diffusion weighted image. Did you have any diffusion restriction in this tumor at all?
No, there was none. It was more consistent with the low-grade tumor rather than a high-grade tumor.
Then I would agree with your proposal to go for the tumor by a transcortical approach. Where would you approach it from? I think this is a left-sided lesion. If that is a dominant side, as we always presume, I think it's a little difficult lesion to approach, but middle temporal gyrus is possible approach as far as I can decipher. Andre doesn't like that, so you have another suggestion.
Professor Groton here.
Well, yeah, I think what I see from this tumor is that many important structures are displaced to the lateral side, to the surface. So if you come from a transcortical, of course you need somehow to go to a transcortical, but middle gyrus, I personally prefer more coming from above. So that but it depends a little bit on DTI. You can do that also in kids.
Yes,
yeah.
I think.
Because then you know how that is displaced. Because
George described it earlier that most of the internal capsule is shifted inside. So
hopefully,
therefore, I thought it may be simpler to do it from.
It's very often not the case.
It was shifted medially, the internal capsule.
Medially, okay.
Yes.
Yeah. Well, then of course, then you can go from this. Well, this is my arrow. Of course, you can't see that, but that's then middle gyrus would give you access, but also from. Well, then of course transcallosal is not possible. Simply, if that is going medial, you can't transverse that. But it's a longer way coming from above, but you often can go really dissect the whole sulcus and then go into that tumor. You have the long axis of that lesion. So if you see the middle figure here, if you come from above, then it is in the long axis of the tumor. Yes, indeed. So you would widen it up for yourself.
Dr. Boop, can I get you to share your how would you approach this, Dr. Boop?
Well, the two other, so to Andre's comment about transcallosal, a normal thalamus is pushed up here. So if you use that approach, you go through a normal thalamus.
That's impossible.
Not a good approach. So for me, I've used either transtemporal, as you've seen in the thalamo-peduncular tumors, or transcortical if the tracts are all pressed medially. The other two important things I would want to know is where the optic pathway is and where the lenticular striates are. And I would try to use an approach that avoided those. Even though he's already got a pre-existing hemiparesis, you would hope that it would be recoverable if you could stay out of the lenticular striates.
Exactly. Very nice. Yeah.
Just a question, George, from me, because I can't see all the images and visualize it as you guys have with a longer career. What about is this not amenable to Transylvian approach to exercise it? Is it from Transylvian go to the bottom and then take it up?
Deal with the insula then, because it is Transylvian alone will not give you enough access to the whole tumor.
Okay.
And these are the low grades. I mean, if you it looks now very nicely circumscribed, but if you are in the surgery, it's more difficult to distinguish. So then it is you have to transverse also the insula. You do all purely Transylvian.
Okay. Thanks.
So, all those we had discussion about all those approaches, and Andres, I chose your approach, going the long axis of the tumor to see if we can remove it. Sorry about that. We'll go this way. And that was the approach that we took. Was a transcortical approach from above. You can see the tract there of the tube, and how low we got. And again, I think it was a very good resection. I think we achieved what I would say was a gross total resection. The histology was a pilocytic astrocytoma, as expected. And you can see that there's already immediate re-expansion of the internal capsule on this post-op day 1 scan.
It's very nice.
Very nice indeed.
And I think the lesson learned here is that, as we said, there's several approaches, whether it's a transfrontal approach or a temporal approach. It's really how to best attack the tumor depending upon which way the motor pathways or the internal capsules being displaced. And Rick, there you can see the optic tracts right there, Rick.
Yeah, beautiful operation. I would just add that we reviewed a case similar to this in our brain tumor conference last week, where the local neurosurgeon chose to do a stereotactic biopsy and happened to biopsy a lenticular striate, and the child has a devastating hemorrhage and is now vegetative. So
really, wow.
Yeah.
Goodness.
Yeah, was it a pilocytic, Rick? I mean,
yeah, it actually was, unfortunately.
You know, again, I've used the tube. If you stay within the tube, the tubular retractors, whether it's a brain path or the Vicor, within the tube, staying within the tumor, you know, there's it should the all your perforators and your lenticulostriates should be displaced and not be, you know, en passant, right?
No,
You're
but
absolutely right. Pilocytics are confluent tumors, and the vessel should be displaced around them.
I think the key is staying within, it's once you're within the tumor, and again, working within the tumor is, if you stay within the tumor, you should be safe removing these. It's just that, you know, the vessels that may be on the capsule or vessels that are being displaced, that one should avoid any electric cautery or thermal, you know, to prevent any thermal injury to the vessels.
But I heard that there was a stereotactic biopsy, and that is, of course, yeah, that has its dangers. So you can indeed damage an important vessel and had a great bleeding. In such a case, and especially in children, I'm not very much in favor of doing stereotactic biopsies. I mean, there is not a lot of differential diagnosis other than pilocytic or DNT. I mean, this is.
A question to George, if I may interrupt. Do you need to change the length of the tube retractors as you go down?
You should, but then there's the additional the cost associated with using several tubes. So I try not to. But that means, you know, you're working, you know, when you first start off with the tube, it's you know, a lot of it is extracranial, and then you have to keep passing it down deeper in as you resect the tumor. One of the reasons I use the same length tube is I end up using the same length instruments, because then I don't have to worry. I get a sense when I'm in there with the instruments. If you change the tubes, then you know, your instrument length, you may get a little confusion there on how deep they are within the tube. So I typically use one tube for all these cases, the same length from beginning to the end.
Can you use an ultrasound with the tube to gauge the tumor excision?
Yes, I stereotaxy to help guide the tube for all these cases. I use the ultrasound to help for intraop. Unlike Rick, who's got the intraop MR, I need an intraop ultrasound to help to ensure that we are getting the resection. And I use neurophysiological mapping. I will do stimulation, direct stimulation, and actually did stimulate the internal capsule there to tell me that I was pretty damn close to it.
Thank you.
Very good.
Going back to Dr. Boop, Dr. Boop, this is quite a large tumor, and if the blood vessels are being pushed out, how did that doctor manage to get the thalamus striate? Do you think that they missed the location, or do you think it was vertical just from a biopsy from the middle of the tumor that caused the bleeding?
It was a needle biopsy from middle frontal gyrus. So I don't know that they got a lenticular striate, but it was a significant hemorrhage. And as you know, pilocytic astrocytomas can be very bloody tumors sometimes, particularly in the basal ganglia. So,
yeah, because the solid ones can be very vascularized. Yes.
Thanks.
And going back to that, that's one of the reasons I don't like doing biopsies for these thalamic or midline tumors not outside of the brainstem. You know, I've seen them bleed, and with a stereotactic needle biopsy, even when they're low grade.
I had a patient. It was an adult. I did an open biopsy. This was when I was a registrar, and you know, it bled, and I spent about an hour controlling the bleeding and all happy, and came out. And then the patient was, after half an hour later, was hemiparetic, almost hemiplegic, because the bleeding stopped outside. The bleeding happened inside. So I did an open biopsy last week, and you know, I have to say I prefer excision than a biopsy sometimes, because I feel I have got bit more control, that that I take all the tumor out rather than biopsy sometimes worries me.
Excellent. No, I agree. Thank you, Naren.
Oh, thank you very much. That was a great session. I thought we had a good discussion. Thank you very much, Dr. Jallo. So we'll now, just to let you know that this is a 4-day course. Tomorrow we have controversies, and we have got 3 controversies. One on cerebral mutism, the other one is on tumor-related hydrocephalus, and the third one is on what we just talked about, intraoperative ultrasound versus MRI. So we'll start again at 1 o'clock tomorrow. Thank you very much again, Dr. Jallo. And now we are going to go to Professor Chandrashekhar Deopujari. Again, Professor Deopujari does not need introduction in pediatric neurosurgery or neurosurgery. He's a doyen of pediatric neurosurgery, past president of the International Society of Pediatric Neurosurgery, past president of the Indian Society of Neurosurgery, past president of the Australasian Society of Neurosurgery, and I'm sure he was president of the IFNE, the Endoscopic Society. But you know, I have known him now for over 10 years, and it really has been, I've learned a lot, and his support for the listserv has been always absolute. And Professor Deopujari, it's a privilege to have you. We look forward to learning from you. Thank you, sir.
Thanks, Naresh. Naren, I think you have probably overstated a few things, but thanks for the introduction. I am not allowed to share the screen right now, so you will have to first allow me to do that.
Sure.
And I'm going to show you. Okay. So I'm going to start with this case, show you some intraventricular cases, 4 or 5 cases. This is a 4-year-old male child. Am I visible on the screen and heard?
Yes, absolutely. Yeah.
Okay. So presented with intermittent headaches for a year, which were more or less generalized, no focal, and some weakness, loss of appetite. But the child actually came to us because of the deviation of the eyeball for about 15 days. There was no vomiting, seizure, gait imbalance. He was 15 by 15, well oriented. VP showed some slowed conduction. Visual acuity was good. Fundus showed moderate to severe papilledema. Extraocular movements, there was right lateral rectus paresis. The rest of the cranial nerves were normal. And this was the scan. So it showed hydrocephalus, and it showed a possibility of a lesion near the foramen of Monroe. These are the T2-weighted and FLAIR images, which show the hydrocephalus much more prominently. And you can see some signal in the third ventricle. This was the contrast scan. And what do we make of this?
George, do you want to?
I would be very happy if my fellow panelists gave their opinions.
I mean, it's interesting. There's a lot of enhancement in the basilar cisterns there, and along. I mean, there's just too much enhancement for me. So I'm looking. Is this a disseminated process, such as a tumor, or an infectious process? I did not get the complete history again.
The child has an insidious onset of headache and presented with 2 weeks history of left lateral rectus palsy.
I think probably a germ.
There is no diabetes insipidus.
Yeah, I mean,
yeah.
And Chandra, do you have a spine MR to see if there's anything on the spine?
Yes. So these are the sagittal images, and this is the spinal image. So you do see a deposit in the spine, which is where better seen on contrast images.
Could this be a germline tumor with an
And this child has been going to school till, the day before he came to us.
Yeah, I don't think it's a germline tumor. I think this is a this is a neoplastic process that's disseminated. It could be low grade, could be high grade, right? I mean, I've seen both, but he's symptomatic from the hydrocephalus with that 6 nerve palsy. And I think that's what he's going to need treatment for first before I would consider that doing a biopsy. I mean, one can consider, shunting him, getting CSF for cytology, see if you can get a diagnosis. If not, then I would approach this spinal thing for tissue.
Well, with hydrocephalus with periventricular lucency and the most remarkable enhancement in the third ventricle, we thought we should first do serum markers, which were negative. And then we thought that we'll do a biopsy from that lesion and do a septostomy. I mean, I do not think third ventriculostomy was a concern, but with the lesion at the third foramen of Monro, we thought that the child may be helped by doing a septostomy so that a shunt can be put later on. For some reason, the video is not working. Okay. So you can see some nodules on the ventricular wall. You can see this kind of a deposit even on the fornix near the third ventricle. So we did a septostomy and we did a biopsy. And this was the post-operative picture. For some reason, his hydrocephalus settled after that. We started steroids after taking the biopsy. And the report has come as pilocytic astrocytoma. No mutation of BRAF. So we looked at the literature. There are dissemination known even in pilocytic astrocytomas, but how do you treat it in a 4-year child who's symptomatic only with left lateral palsy? I would like to know, maybe Dr. Boop can tell us, or
well, it's an unusual case, but we certainly see it. The literature would suggest that about 5% of pilocytics may disseminate at some point. I think in a 4-year-old, our group would recommend low-grade chemotherapy first. Tom Merchant has a nice paper out on craniospinal radiation for disseminated low-grade tumors in children, but I don't think he'd have much enthusiasm in a 4-year-old.
So our oncologists actually felt that they would treat this child with radiotherapy. And they actually went ahead and radiated this child, who tolerated it well. In fact, his 6 nerve palsy also disappeared when he came for a follow-up at the end of radiotherapy. But 3 months later, he developed frequent vomiting. The CT scan showed ventricular size, and a unilateral shunt was sufficient to take care of that. I have just seen this child 2 years follow-up. Unfortunately, they did not bring the MRI with them, but the scan shows we have an oncology center which is separate, and I could not see the films, but they are saying that there is no enhancing lesion anymore seen either on the brain or on the spine. So I thought that was quite interesting.
Professor Deopujari, shall I just bring our neuro-oncologist in our audience.
Yes, yes.
Dr. Steve Lois, any comments, thoughts, and Dr. Meta Jorgensen. First of all, Dr. Stephen Lois.
I don't think I got anything to disagree with, really. I mean, if you've given radiotherapy and there is no residuum, then you've kind of done what you wanted to do. So I don't necessarily.
Would you have given radiotherapy if it was before? That we know that after radiotherapy here it worked well, but from the outset, would you have gone for chemotherapy, or like in St. Jude, or you would have gone for radiotherapy?
Remind me, how old was the child?
4-year-old.
Yeah, you probably would be going through
4.5 years, closer to 5 years.
So a little young, and I think generally we would be more reluctant to use radiotherapy in a child under the age of 7, I think. But it depends on the circumstances of the child. If chemotherapy itself was going to cause significant problems.
Thanks, Dr. Jorgensen. Have you had similar patients in your practice?
Yes, we see quite a lot of young children. Can you hear me?
Yes, yeah.
So I see quite a lot of young children with metastatic and disseminated pilocytic, and we would always treat them with chemotherapy. Carbovink would be our first choice, really, particularly given the age as well. But I guess there's always different preferences.
Thanks. Thank you. That's great. Thank you very much. And how's the Professor Deopujari, any word on how the child is doing cognitive-wise?
Child is doing actually quite well. I mean, child is doing school, child is playing. It looks like a normal child. When I saw him at a 2-year follow-up, I did not believe that he was doing so well. And though I have not seen the scan myself, the radiation oncologist tells me that it looks pretty clean.
That's great. Thanks.
So if I just say I agree that the chemotherapy for a metastatic tumor is what we would normally try, but I've got a couple of patients who've had terrible times with recurrent progression and complications from chemotherapy. And again, it is dependent on, I think, what the supportive care available to the family is as well.
Certainly is what's safe and can be delivered, right? I agree.
That's great. Thanks. Thank you, Dr. Lois and Dr. Jorgensen.
Shall I share
Thank you.
another case?
Please. Absolutely.
Yeah.
Thanks.
So this is actually, both parents are doctors. One of them is actually a pediatrician, and they brought their child, 2 years old, with frequent vomitings over the last 1 week. And by the time the child actually came, there was some drowsiness and decreased activity, and fundus showed papilledema, and there were bilateral extensor plantar responses. This was the scan. Hydrocephalus, and there is a mass lesion in the third ventricle, posterior third ventricle, which seems to have a much larger extent than what we initially thought. This was the FLAIR image, and these were the contrast images.
George, do you want to make any comments? Thanks.
Looks like a pineal-based mass lesion, to be frank, arising from that area, pushing the cerebella down and going everywhere. So my money would be something pineal-based.
So is it reasonable to offer the child direct surgery, or should we do a ETV and take a biopsy first?
if you ask me, I think it's going to be vascular, so I would probably go for the surgical bit directly.
George, how would you do it? Would you go for biopsy or surgery directly?
Hi, Darren. Sorry. I would probably do an endoscopic third ventriculostomy and a biopsy at the same time before the more formal surgery.
Yeah, I agree. That's going to be a long surgery in a sick child. If he's got extensor posturing, I'd rather do the ETV and biopsy. Endoscopic biopsy, you can see whether it's bleeding or not, or try to choose an avascular area to do the biopsy.
The other is, one can always stage it. Once you have the diagnosis, consider some chemotherapy options before the formal surgical approach, if needed.
Before direct surgery, yeah.
Yes.
So that is what the thought was, and we discussed it. Both parents being pediatrician, it didn't. It took quite some time for them to, first of all, accept and agree to go ahead at least for a biopsy. And you can see that here also there is already a deposit here, which doesn't enhance very much, but you can probably see it. So I went ahead and did a third ventriculostomy. Not able to. This was the kind of tumor after doing the third ventriculostomy. We could take large chunks of biopsy from this. It didn't bleed very much. And rather than coagulating, started using actually the Fogarty balloon itself to compress on the tumor bed, which is giving us a reasonable kind of a hemostasis. So that's the way we have been able to control the bleeding here. And the report is ATRT. The child remarkably improved. I must say that first, that the child improved remarkably. The parents were quite happy. The child started feeding almost from the next day and responded to them quite well. The eye movements looked okay, but this was the final report.
Dr. Boop, any thoughts? Next step?
Well, in an infant with metastatic ATRT, the chances of long-term survival are very poor. I believe there are 3 subtypes of ATRT based upon molecular profiling now. Nice paper by Santosh Udapajaya. A family like this is going to want to have everything done, I suspect. The interesting thing about this, back to Ibrahim Qaddoumi's talk on presentation in children with brain tumors, is here's a child who lives in the family with a pediatrician and comes in with extensor posturing before the diagnosis is made. I think that's very telling. But we would treat with protocol therapy and the child would probably not do very well.
So Rick, exactly this is what the oncology team and all of us discussed with them, and both the parents decided not to go ahead with any further treatment on this child.
Well, I'll tell you, I had an infant with an ATRT whose mother and father were both physicians, and they came down wanting therapy. And we gave the child chemotherapy, did a resection. The child lived 6 or 8 months. And when they died, the mother sent me the most beautiful letter about how in that time, she'd gotten to see her baby learn to crawl, learn to walk, how she would never forget the baby's laugh, and how much that time meant to her with her child. It's a letter I've kept because it meant so much to me in a child whose prognosis was hopeless to begin with.
Dr. Stephen Lois and Meta, again, have you had similar patients, and what happened with them? Did you guys give chemotherapy or treated conservatively, Steve?
Yeah, well, I mean, by coincidence, I'm CI of the European ATRT01 study. So the short answer is that not every family would be prepared to not give therapy, and therefore we often do end up treating. If you can get a child into complete remission, then actually the prognostic implication is not quite so poor. If you ever get into CR, even with metastatic disease, then approximately 40% of children can be cured. So it isn't automatically the case that one should not offer therapy. That being said, the large majority of infants with metastatic disease never do get into CR, and then the options are very limited.
Sorry, Steve. What do you? I don't understand CR. What does CR mean?
Sorry, complete remission.
Okay.
Yeah, sorry. So if you can, even the aim for ATRT is always to try and get complete remission. So often that's done at the time of diagnosis by the surgeon removing the tumor completely. If you can't do that, if you can get the patient into CR by induction chemotherapy, then they are curable, albeit not so curable as patients who are initially in CR. And the other thing to say is that whereas radiotherapy has been the standard for just about everybody until now, there is an increasing body of evidence to suggest that you can treat these patients effectively with high-dose chemotherapy, and indeed that's what the randomized study in ATRT01 will be looking at.
Thanks. Dr. Jurgensen, anything more to add? Do you have had similar patients, and is your routine for chemotherapy, or once again, you speak with the family regarding conservative management? Thanks.
I think we do all of those things. We offer them no treatment, and we offer them an attempted treatment. But otherwise, I entirely agree with what Steve Lois has already said. That's very much the approach. But we tend to try, and I agree most families are grateful for the time we may be able to get them. But it's a pretty tough treatment, so you have to have a supportive care around it. Tight.
Naren, we are running late. Can I just show one quick case? Dr. Naren?
Yep.
Can I just show a quick case? I think we just discussed something with George on this case. So this child actually is only 2 months old and came to us with not a very common location, with this lesion, with bulging fontanelle and downward gaze. George or Rick or Andre, would anybody comment what to do on this 2 months old child?
It looks like a chorioplexus papilloma.
Absolutely, it looked like plexus papilloma.
Yeah. So how do we treat this 2 months child?
I mean, 2 months is really, it's, this will be a team effort, but this is amenable to surgery even at that age, Chandra. That's, it's possible. I mean, it's, we call this erythrocyte chasing. So even with the skin incision, you have to to prevent any type of bleeding. So that is what I mean with team effort. You have to replace, it's about the possible blood loss that you have. But usually if you are there, these are large ventricles. If you are there, the cord plexus papilloma itself does not need to, will not bleed as a lot. You just have to prevent that there is massive bleeding. Otherwise, you will lose that child indeed. But I have a nice video actually of a 4-month-old child with a similar location where we did. Actually, that child also had this septum pellucidum cyst, exactly the same. Maybe that is very common in young children. But therefore, I still would go for surgery. But this is the kind where time out, sitting together and planning that is extremely important, so that everyone knows what to do in such cases.
I would argue against that.
George, is there any role of interventional treatment?
No.
Would anybody try embolization or
2 months old? Our interventionist will not even try to do that in a 2 months old. And I know that some people will say you can treat that hydrocephalus and then wait for some months getting older. Yeah, well, that's a possibility, but I'm okay. Rick, please go ahead. I'm curious what you will say.
Well, the problem with a 2 or 3 month old with massive hydrocephalus is that once you open the corpus callosum to do the surgery, the CSF comes out and the children get cortical collapse and they have big subdurals, and you have to contend with those for a long time. So the DC Children's Group has a 3-month-old that they had a tumor just like this, same location. They embolized it and the whole tumor involuted and went away, and the child never had to have surgery.
Really?
We had one that was 4 or 5 months old with a 5-centimeter third ventricular papilloma that we shunted and embolized, and his ventricles normalized. He made good developmental progress. The tumor involuted down to about 1 centimeter. And when he was 1.5 years old, we went in transclosally. At that point, it was very easy to resect. So I think there are good reasons in a 2 or 3 month old with massive hydrocephalus to temporize. Dr. Deopujari is so good with an endoscope, he may be able to do this through an endoscope. And if that's the case, then you might be able to do it at this age. But
this is not an endoscopic case, I can tell you. No. You need bimanual. I mean, Chandra, would you ever consider doing something endoscopically here?
So I have actually used endoscope, Andre, in choroid plexus tumors, especially in the temporal horn and in the atrium, because you can actually take the feeder first.
Yeah,
I have not used it to excise the lesion, but if you take the feeder first, you go around it, it becomes much easier to get the tumor out, and you can actually fragment it if it becomes necessary, rather than trying to get the whole tumor out through a large, channel.
Mm-hmm.
So I have used endoscope, but not for a complete excision. No.
Well, and actually, I would not go transclosally. I would go through the ventricles, so transcortical, transventricular. And yeah, then that is. But I am very surprised because our interventionalists, they 2 months old, they will not say no.
I think the Gosh people have also reported something similar.
Fantastic. I have to show it to them. Yeah.
So actually my younger colleague, I was not in town at that time, and my younger colleague who's done his fellowship at Gosh, he actually thought the same. And what he did was he did put a shunt, but at the same time, he also took a biopsy. He wanted to know if it was a choroid plexus papilloma or a carcinoma, so that we can, decide about further treatment. This is what happened. About 2 weeks later, I saw this patient, and for a completely different problem. The raised ICP problem got resolved. But then the report came out to be choroid plexus papilloma. And this child developed such a big ascites that it had to be tapped virtually every day. After 5 days tapping, we actually, the surgeons decided to put a PIC catheter, as they call it, and drain it. And every day from the abdomen, more than 300 cc's fluid was coming for the first 2 days. So the shunt was exteriorized, and we were forced to go for surgery. Daily CSF drainage was about 300 cc's, and the boy was doing okay, but had to have, I mean, we're worried about not only the metabolic parameters, but so much of loss and the child becoming unstable was a real issue. So we explained to the parents the risks of surgery. Our interventionist did not attempt embolization in spite of requesting us. So I went in and excised this tumor at that time. So this is the only patient. You were asking, Andre, why the child has developed hydrocephalus. So I think this is another reason why the excessive CSF production, I had only thought as a theoretical possibility, but this is one patient where I have actually seen it, and it had stopped only after this. No, this was operated about 2 years ago, and the child is doing very well.
Now, in the milestone. Dr. Jallo, it was in the lateral ventricle, but here it is the third ventricle. So then it is very comprehensible to develop a hydrocephalus. Absolutely.
Yeah, I have a similar experience with a craniopharyngioma, which an endoscopically was fenestrated and biopsied, and an external drain was put. And similarly, like you, Professor, we had drainage of 300 plus every day. And we put it in the tummy, but within a month, the ascites used to be so bad that we had to kind of think about something else. But meanwhile, this patient needed proton beam, so went to stage. Dr. Aldana put the catheter in the gallbladder, and the gallbladder became such badly distended when she came back to us. The gallbladder was larger than the liver. I had to take it out and put it in the heart where it normalized everything. And it is sometimes surprising that even a small amount of irritation of the choroid plexus by anything else can also give rise to similar things. So it is interesting. It doesn't happen more often.
Mm-hmm. Chandra, what approach did you use in that child?
I went through the frontal horn.
Mm-hmm. I would agree with you.
Right frontal horn. Yeah.
Yes.
I did not attempt a transcallosal because I could not show you the picture. After the shunt surgery, the ventricles had become a little smaller, but they were still fairly accessible for a transventricular approach.
No, I would have done the same. Exactly. Yes. Yes.
Great operation.
Stephen is telling us that chemotherapy has been used in choroid plexus papillomas. Maybe he can.
Just an example. Only ever once in my practice, but there's a couple of publications where people have used preoperative vincristine to reduce the vascularity of the tumor, and then gone in to do a secondary operation a week or two later.
I think there's that ICE trial which was used, but it didn't show that it did too much about it.
And just as an aside, my colleagues in neurosurgery once reported a 15-volume blood loss in a patient with a choroid plexus papilloma. A successful operation, but 15 volumes was probably the record we had.
I think personally these needs to be staged if the child is very small. And I had a 4-weeker when I started with a large papilloma in the lateral ventricle. So initially just meant for only 10-15% excision with reduction in the volume by reducing the blood supply of whatever vessels I could see from outside. Waited for the child to be 6 months and then got it all out.
So, any more cases? I think we are far beyond the time. So,
if you have another case, Prof, that would be great. Thanks.
Thank you.
I can show one more case if you wish. It's a purely surgical case, or just one moment.
While Professor Deopujari is getting the next case, Dr. Mette Jorgensen, in terms of embolization at this age, do they do it in gauche?
Sorry, I was listening, but in the process of doing something different.
Sure.
We do. So we have a dedicated neurovascular, interventional neurovascular team. So they do, because they also give intra-arterial chemotherapy that way. So we do have the expertise. I don't know 2 months specifically, but we do in very young children. So yes.
Thanks. Thank you.
I will share one more case. This is a 10-year-old boy who was playing in school and had a fall and came to us with actually a scalp hematoma. And he said that his doctor asked him to get a CT scan done, his family physician, and then he said to go to a neurosurgeon after seeing the scan. So this was the scan.
Hypointence on T1 at the foramen of Monroe.
No, this is a CT.
This is a CT.
Sorry.
Yeah, hyperdense lesion on
the
this.
Hyperdense, sorry, CT.
Yeah.
I think you already answered the question down there, isn't it? Colloid cyst.
Right. So it is a clear-cut colloid cyst. It's about 7.5 millimeters according to their calculations, and the child is absolutely normal.
So, Dr. Boop.
Well, if it's a normal child and an incidental finding and a reliable family, then I follow these. I've had one case where the child was developmentally delayed and the family was not reliable, who subsequently showed up in the emergency room decerebrate when he developed acute hydrocephalus. But I don't believe in the current era that the idea of these being pedunculated and swinging back and forth and suddenly obstructing the ventricle is accurate. So I follow these patients and frequently advise them the symptoms of raised intracranial pressure.
Thanks. Dr. Grottenhuis, you have got a particular interest in colloid cysts?
Andre just got out, I think. George may be able to tell us.
George?
Yeah, no, I would agree. I make sure there's no papilledema. And I'm similar to Rick. I think this is an incidental finding. I'd educate the family, and I would just follow him to ensure that he doesn't grow or it doesn't develop symptoms.
Absolutely.
Professor Grottenhuis, is that the same thing with you?
Yes, absolutely. In this case, I would no single neuron in my brain would even think of advising surgery in this case. Absolutely not. This is something to follow up, and it's small. There is no hydrocephalus. There are no symptoms, so no way to do anything here. It's a pity that a CT scan was done.
So it has put me in trouble. I'm looking at some of the literature, and I find that in very young patients, it can be variable. And though the usual clinical presentation is with raised intracranial pressure, either paroxysmal or continuous, you can get incidental patients. However, the reports of sudden death, as Dr. Boop has just said, in fact, I have two patients, one of them teenager, who actually presented in a stage beyond doing anything during last 25 years. And the sudden death is not only because of hydrocephalus, but sometimes it can also be with just hypothalamic symptoms. This is what the literature tells us about the mechanism of sudden death. What is most, what has come about in last 2-3 years, I think this is a 2018 paper, that if you have a diameter of more than 7 millimeters, you should consider surgery. And the other consideration is the risk zone. This is a relatively posteriorly placed kind of a cyst. It is just behind the foramen of Monro or just at the back end of the foramen of Monro. So that becomes an additional risk factor. The family was quite well educated. We discussed all this between observation and possible surgery. And I must say that I thought that with this 7 millimeter patient, if there is no hydrocephalus, you are probably okay. But can I justify saying that it is not necessary? And when they agreed for surgery, the question was the safety of surgery. So I looked at this, and it was quite clear that one cannot do any kind of endoscopic surgery with such small ventricles and the cyst being so far back. So I actually have, I think everybody is aware that you can operate through the septum, you can do through the choroid fissure. And we actually enlarged the foramen in this child by the just under the choroid plexus, and then removed this cyst by a microscopic transcallosal approach. And it was a colloid cyst. And luckily the child is quite well and is back to school in 3 weeks' time. I don't know how much importance to give, as Dr. Boop said that, but having seen at least one teenager, who suddenly gone, I do discuss with patients. It's not very common in children. This is in fact only the 10th patient below 16 years that I have operated. But I think the literature is not very clear, and observation can probably be done if you can closely follow the child. That I entirely agree, but this is what is been done for this patient. I am very happy to hear any critical comments.
Professor Grottenhuis?
The last sentence is important, Chandrashekhar, that is, can you ensure that that child would have a good follow-up? So really show up regularly with scan, and probably in our region that would be easy to do. I don't know how it is in your case, because very often, though, I know in India, the people have to pay for the scans, so they would not be very happy to pay that, let's say, every 6 months. The other comment is that the risk of sudden death is rather overestimated. Of course, these are all case reports, but has been a study coming from the Netherlands, the Withamer, and they studied 90 cases, and they say the risk is 40%. Not true, because they look at those patients that were presented acutely and in coma into the hospital. And I can imagine, but this is a different group of patients. Many of these incidental findings will not have hypothalamic disturbances. Many will not develop hydrocephalus, and that for me is the reason. If you would say it comes from a little village, and it is a burden to the family to do that. And as you said, this is no case for endoscopy. You know that there are some colleagues who would do this endoscopically and then describe how they blow up the ventricle to get access. That is not for me. I mean, I have done a lot of endoscopic cases, but not with these small ventricles. So then I think your approach is correct. And I think at the end you are right, Chandrashekhar, because you have treated this child. It's not a patient anymore. That's a good thing. The drawback of controlling and following up means that that child is a patient forever. Even in 10 years, we'll need scans because, oh, you have a colloid cyst. So if you really treat them and you remove it completely, they are not patients anymore. They are cured. This is one of the few lesions we really know that we can cure surgically. So I think at the end, your result is perfect, and I just congratulate you. That's it's done wonderfully. If I see the scans, fantastic.
I have 3 questions in my mind that when we decide to observe a patient, this published this score, risk score, gives importance to age of the patient, gives importance to size of the cyst and the location of the cyst. In your experience, even George and Rick can share, do you think these things matter? I mean, is every colloid cyst the same? That is something which we do.
Well, in that risk score, the cutoff age is 65. So if you are 63, correct, you have a higher risk than when you are 67. Well, that's always arbitrary. I agree with you that the younger somebody is, and this is a very young child, I mean, it's a child, but the younger the patient is, you don't want to put them to the burden of, as I said, prolonged follow-up and always knowing. Just imagine if you follow them up and they are adults and they want to buy an insurance. They will say, no, you have a brain tumor, so we don't insure you. You don't get a mortgage. So, I mean, there are a lot of practical problems for these people if you follow this up, and they have that still in their brain, and we know it, and they know it. So the moment they wake up with some headache, they have to go to the ER and show you. So there is also some drawback of just doing follow-up. It sounds so easy, but for the patients, it's not nice knowing that they have something like that. For the child, probably not, but the moment you are an adult and you realize that, that's also a burden. So we have to weigh that and discuss the pro and cons of the risk of surgery. And that's a one-time risk, and the lifelong risk of not knowing what will happen to me. So this is one part. And this, absolutely, I don't know, why 7 millimeters? For me, it was always about 10 millimeters. That was long before this came, because I said that's about the size of that would block a foramen. And but that's also arbitrary. So if it is a 7 millimeter in a 76-year-old, that's fine. If it is 8 millimeters in a 63-year-old, that's 2 point more, it is surgery. I am somewhat, you need much higher numbers to really validate that.
Right.
I would comment that one of my adult partners now has 4 or 5 patients that had endoscopic surgery for colloid cysts where it was incomplete resection, and over time the colloid cyst reformed and grew back.
So, absolutely.
And so unless you can document that you've gotten it all out, it may grow back, and they do have to be followed.
I fully agree, Rick, because this is one thing that it is no good. So this is excellent what Chandra did. This is removing it completely. If you think of surgery to this lesion, this is also what, even if there is hydrocephalus, what I promise my patients, when you wake up out of surgery, that cyst is gone. I start endoscopically. but I'm not sure that it is all out, I proceed microsurgically. I didn't have to in the last, well, more than 20, 30 cases. I can't exactly remember that, but you need to have a total removal. Just opening the cyst, remove of the contact, then coagulate it a little bit, that's not a good surgery in my opinion. Because as I said, this is a lesion we can cure surgically. And that is what we should offer to the patients. If you offer endoscopic surgery, you should be capable of removing it completely.
I've got a question to Dr. Boop. Means if you say that this patient can be managed conservatively, what are the risk percentage you say that this patient has got a risk of sudden death? And then second question to that is how often you follow up and how often you do the scans?
Well, that's an excellent question. You know, in the older literature, when they talked about sudden death, it was generally in people who presented with hydrocephalus and mild symptoms or no symptoms. And I think when those patients have sudden death, they probably had a plateau wave or something similar to George Jallo's case recently that he presented where they herniate. I'm not aware of someone who's suddenly died from a small colloid cyst who had no hydrocephalus. So I typically will see them yearly and get a scan. If it's stable for several years, then either go to every other year or tell them to call me if they start having headaches. The one patient I got into trouble with belonged to a family. He was a young adult who was developmentally delayed, and we followed this colloid cyst. And he married another developmentally delayed person, and the family bought them an apartment where they stayed by themselves. And he didn't wake up one morning and came to the ER decerebrate. And fortunately, my partners were able to salvage him, but that's the only case I've had of someone get into trouble from following a colloid cyst. And in retrospect, not a reliable child. And that was my mistake.
I think this similarly, if there's a child, then it becomes difficult to say that what symptoms to look for, especially smaller children who probably do not understand how to complain that they have a problem with their vision or can't tell that they get a headache. Then it becomes more difficult if someone who is not verbal yet.
Yep.
Nearly all of these kids are older, those children. They tend to be teenagers, the ones I've seen in children that present. And, you know, my understanding of the literature, I'm kind of with Andre that 10 millimeters is probably a better cutoff for considering risk factors. Again, where you've got large series of cysts that have been followed prospectively, I don't think anybody's reported prospectively followed cysts where the patient has knowledge of the cyst, that they've not been able to access neurosurgical services in a timely fashion. So, and you know, if you go back and speak to these patients post procedure, even the ones that present precipitously, they've always had several hours of prodromal headache before they collapse, and it's just they're misdiagnosed as some other cause, and most of them actually have sort of grumbling on-off headaches for several weeks often prior to collapse. So I've yet to buy into the sudden death thing, and I don't buy into the hypothalamic sort of disturbance causing you to drop dead. I mean, I just don't buy it. But I mean, the only thing we have done, Andre, with the ones with slightly plumper ventricles, perhaps, is just to use a robot-assisted endoscopy. So if you use the sort of Neuromate to get a trajectory, and that, because you've got the hand controller, you've got much more control over the scope in a tight environment, and so we have used that to facilitate things. But in general, with the smaller ventricles, it's a lot safer to do a quick interhemispheric approach.
Oh, no,
we had a patient who died waiting for surgery next day. We came overnight. So I have seen patient die with a colloid cyst.
Yeah, but that was waiting for surgery overnight, Shalindra. You know, it's like they all. If somebody presented with a colloid cyst, they need immediate surgery. But you know, but most of them have a prodrome. You know, like for hours, they get to a medical services, don't they? So
usually they do, but of course, I think everyone dealing with such patients have seen one or more devastating cases. I remember a young lady with a colloid cyst with hydrocephalus that we admitted to the hospital, said, "You come on Friday, we will do the surgery." She arrived on Thursday morning, decerebrated. So she arrived in a coma. I mean, we already knew it. It was scheduled, and still she arrived. She had a hemorrhage in it. I mean, these are rare cases. We cannot make all our decisions based on these very sad single cases. And I agree with you, Richard, that if the ventricles are a little bit enlarged, then I still use endoscope, but I use the transchoroidal approach. So I widen the foramen transchoroidally, but then with the endoscope. And then you have a nice access to the origin of the cyst. We have described that with the group from the Mayo Clinic in Florida and with Buffalo, people that I trained endoscopically, and we did a whole series of that. So that is also a possibility.
One other reason to put up the case was that, you know, a 10-year-old child may or may not be able to, you know, give a reliable account of what is happening to him, and may not understand the prodrome. And
yeah.
So do we take age as criteria? When I said that 65 cutoff is not what I was actually trying to say. I was trying to say that a very young patient, should we have a different criteria?
Maybe.
Say anybody below 12 years. Or
maybe because, well, I think that 10 or 12, they can say, I mean, we know now that, let's say, a child of 4 very often don't complain about anything. They hardly say a headache. If they have bad vision, they just move up front to the television. I had patients nearly blind at that age that just were seen sitting more or less 10 centimeters in front of the television screen before they noticed that the child was nearly blind, because they never complained it by themselves. If they are older children, well, I think even a 10-year-old you can instruct. It would be difficult, you instruct parents, but yeah, it's difficult to make really a cutoff age there.
That's great. Just 2 points is that I think when Harvey Cushing passed away, they did when he had the autopsy, they found the colloid cyst. So you know, Harvey Cushing lived through his life with a colloid cyst. But I think there are 2 different populations. I think that that's what you were trying to say, that one patient comes without knowing that he had a colloid cyst, who comes in extremis, which I had when I was training, not myself, but I was a registrar there. And then there's the other ones that you incidentally find, and the other ones that you have a headache and then you do a scan and then find. So there might be a couple of different populations. Just going back to that choroid plexus case, just you know, I don't have what I'm saying is one small tip I got in Bristol. You know, you mentioned that if you go transcallosal, then you end up having subdural hygromas, and I have seen it in Birmingham. But it was not for I had a patient when I was in Bristol who had an ETV and then had a subdural hygroma and large ventricles. And in the past, I used to put basically a shunt and a subdural catheter, then use a Y connector and then connect it to the valve and then put it into the peritoneum. But in Bristol, Richard said me to put the ventricular catheter, then connect it to the valve, then distal to the valve, connect a Y catheter, and then put that subdural catheter to that Y connector, and it worked like a charm, because basically the subdural catheter was without the valve, and it was nicely draining, and the brain was pulling up, whereas the ventricular catheter did the hydrocephalus, so the brain really beautifully expanded. So, you know, if you ever have any subdural hygromas, you know, just worth trying. As I said, I can't tell you on one case, but that really worked nicely. But, you know, whenever I used to put the connect the ventricular catheter and the subdural catheter to the Y connector and then connect to the valve, it usually doesn't work well. But with this one that Richard said, that to connect that subdural catheter distal to the valve with a Y connector, it really works like a charm. So, you know, worth just thinking when you have that one. If it works, let me know. So I think we had a fantastic day today. You know, we had legends going through, you know, starting with Professor Dr. Eric Buffet, talking about, you know, worldwide neuro-oncology, and also how to reduce burden so that you know, radiotherapy is reduced as much as possible, so the children can have a good cognition. Then we had Professor Dr. Alan Cohen giving us a fantastic lecture on the advancements advancements in brain tumor, surgical as well as neuro-oncological, with the new molecular biology and advanced techniques and advanced instruments. Then we had these two fantastic lectures initially from Dr. Qaddoumi on early diagnosis and how that can be improved through education, and then from Dr. Moreira on the educational intervention that they are doing in St. Jude in a very, very systematic way with a high impact. Then we had fantastic cases from Dr. Jallo that we all discussed, and again with Professor Deopujari. Really I certainly enjoyed it. I hope you enjoyed it, and it was great to have the neuro-oncologists and neurosurgeons in this forum today to put the different aspects. So thank you very much to everyone for this fabulous day. Tomorrow we have our last day, the 4-day, and we have got that three controversies. First one is on cerebral mutism. The second one would be on managing hydrocephalus in tumor patients, and third will be intraoperative MRI versus ultrasound. So I wish you all a lovely, lovely evening. As I always, Dr. Professor Grotenius, can I just get you to say some words? That will be a nice way to close. Thank you, sir.
Oh, that's an honor, Naren, and I think you have managed already. This is the 3rd day to give a beautiful overview of pediatric neuro-oncology, and I think what I noticed is that the amount of participants stays stable until the last moment of this course, and that's always a good sign. I think it's an open discussion, and this is very important. Therefore, I think that these type of educational events will stay. I mean, you know that we have started it by more or less out of necessity when the pandemic started, but this is an amazing possibility to exchange ideas and to educate in different areas of our specialty. So I think we all will look forward to the last session tomorrow.
That's great. Thanks. So now that you just raised that thing, Professor Grotenius, if Dr. Boop is there, Dr. Boop had a session on Titans, what do you call the Battle of the Titans, on education after the coronavirus. Dr. Boop, what was this outcome of that Battle of the Titans, Prof?
You're talking about COVID?
No, the education after COVID and what we learn from here, which ones we keep.
That our whole world is changed by what is available online. And there are lessons to be learned. Now that we're having meetings in person again, we all realize that there are much that we gain from being together personally, not just limited to the Zooms, but that Zoom is able to extend what we're doing worldwide to a larger audience than we've ever had before.
Absolutely.
Thanks. Thank you very much. Thanks, Richard, for the comment. And I look forward to seeing you. If you can make it, that will be great. Tomorrow at 1 o'clock. Wishing you a good rest of the day wherever you are. Bye for now.
Thank you, Naren. Have a good day.
Thank you.
Naren. Goodbye.
Bye.
Thanks,
Bye-bye.
Naren.
Thanks to you. Bye.
Thank you. Bye.
Thank you. Bye. Thanks, Chandra.